oncological management for distal ureteric and the bladder curve has been the subject of debate. For a high-grade urothelial carcinoma, radical nephrectomy has been the standard of care. Case report: a 55-year male patient presented with left loin pain, no hematuria, and he has a history of tobacco smoking over 20 years. On evolution, ultrasound abdomen shows left moderate hydronephrosis. CCT abdomen pelvis shows moderate hydronephrosis with abrupt narrowing of the distal ureter with isodens enhancing lesion in the lumen, left ureteric lumen measuring 20 into 9 mm with minimal adjacent fat stranding with moderate cortical thinning and no enlarged lymph nodes. Cystoscopy was done. It was normal. And left ureteroscopic biopsy of the tumor, which is 2 centimeter from the VUJ, shows papillourethral neoplasm of low malignant potential. And ureteroscopic wash of fluid shows no malignant cells. MRI abdomen and pelvis was done showing T2. There is a kink in the proximal one-third and a T2 hypo-intense lesion in the left distal ureter, likely ureteric mass. Because of the there is moderate hydronephrosis, thinking of cortical thinning, we went into nucleotide renal study, which shows 10% of differential function, and GFR is 8.5 ml per minute. And we went with left open kidney incision and Gibson's incision, left nephrectomy with bladder cuff resection, and the HPE shows infiltrating urothelial carcinoma of the ureter with severe dysplasia in the renal pelvis, and the distal ureteric margins are negative for invasive carcinoma. We can conclude that nephrectomy is the standard of care for invasive tract urothelial carcinoma and for the distal ureteric malignancy in a case of non-functioning kidney. And open nephrectomy is the gold standard for the management of high-grade urothelial carcinoma. Thank you.
What is the purpose of presenting this?
Sir, the distal ureteric malignancy now setting was very low, sir. And management of distal ureteric malignancy is of debate. And when you do ureteroscopic biopsy, it was showing low malignant potential. We were in confusion whether to provide with resection of the ureter and with anastomosis. But because of hydronephrosis, we went with nucleotide study, and and it was showing the non-functioning kidney. Got a clear cut. We can proceed with nephrectomy. The lower tract is.
I think there is no dispute in doing a nephroureterectomy with a bladder cuff. Bladder cuff is a part and parcel of a nephroureterectomy. That's one thing. And in the second point, when you mentioned the histopathology, there was no mention whether it's a T2, T3 disease or not.
T2 also.
And a template node dissection of that area is always mandatory when you have a lower ureteric tumor.
Pathology, it was showing PT2. P2 N0M0.
In template lymph node dissection was done.
Thank you.
The next call upon Dr. Harshavardhan.
Second.
Wait, Siraj, doctor.
Would you like to give intravesical prophylaxis?
Because in this case, the patient is on follow-up, sir, and after 1.5 months now, patient cystoscopy one is for findings are normal.
I think we have to give. Because
Sir's question is,
tumor.
Sir's question is, did you give any intra-op or immediate post-op mitomycin is what is?
No, the follow-up, you have to think of a BCG.
No, sir.
Mitomycin is indicated. Mitomycin is indicated, and
of late
follow-up for the bladder is indicated.
Yeah, protraction. Don't give prophylaxis.
It's upper tract lesion and nephroureterectomy is done. Bladder prophylaxis is not required.
I think if you see the recent literature advocated,
Thank you, sir.
Next call upon Dr. Harshavardhan from NIMS, presenting a rare case of primary squamous cell carcinoma of left renal pelvis.
Good morning, everyone. Today I'm presenting a case of primary squamous cell carcinoma of left renal pelvis. A 57-year-old female admitted with complaints of hematuria and burning micturition since 1 month. There was no any significant past history and no other lower urinary tract symptoms. And her general physical examination was normal, per abdomen examination and genital examination were normal. And routine lab investigations were sent where she had anemia with hemoglobin of 10.2 and urine routine showed 6 to 10 RBCs and creatinine was normal. And ultrasound abdomen was done initially which showed left lower pole hypoechoic lesion in the left lower pole of the kidney. So CECT abdomen was done which showed bulky left kidney with perirenal fat stranding, facial thickening and moderate dilatation of the PCS. And there is the hypodense lesion in the lower pole of left kidney with enhancement of 5.2 into 3.9 centimeter. And lesion is infiltrating the lower calyx and renal pelvis and proximal ureter. So patient was planned for left radical nephrectomy and PET CT was done preoperatively, which showed metabolically active left RCC with left renal hilar lymph nodes. So left radical nephrectomy was done and gross examination showing a solid tumor in the renal pelvis, which is involving the lower calyces. Histopathological examination showed well differentiated squamous cell carcinoma of the renal pelvis with grade 1 and pathological staging of T3 and N0. So primary squamous cell carcinoma of the renal pelvis is rare and represents about 0.7 to 7% of the upper urinary tract cancers. The incidence of SCC is about 6 times higher in the renal pelvis than in the distal ureter. And they're usually moderately to poorly differentiated by the time they present and they're already invasive at the presentation. So thank you.
Any pre-op ureteroscopy or anything done because it's a tumor extending into the renal pelvis and upper ureter, you said?
No, sir. There was no any significant past history, sir. No history of renal stones or any renal catheterization or ureteroscopies. There was no past history of any such intervention. It was a squamous cell only, sir. No, sir. No previous history. Sir? Adrenal, no, sir. Since it was lower pole with interim adrenal.
IHC to see the exact characteristic, immunohistochemistry characteristics of the tumor?
IHC, no, sir.
Because squamous differentiation and squamous cell will be very similar. Let's you do IHC.
Okay.
Very rare to find a squamous cell, primary squamous cell
Yes.
carcinoma involving the lower calyx. Or
Next call upon
Thank you.
Dr. Thank you. The next call upon Dr. C. Sai Krishna from Kurnool Medical College, presenting blunt renal trauma in pre-existing hydronephrosis, a rare entity.
Very good morning to one and all. It's a blunt renal trauma in pre-existing hydronephrosis, a rare entity. Coming to introduction, the majority of renal trauma are blunt trauma, usually in motor vehicle accidents. Renal trauma in hydronephrotic kidney due to UPJO, that is uretropelvic junction obstruction, is a rare entity. This condition is a risk factor for higher grade injuries. And hereby I am presenting two case reports. That is case 1, he is a 30-year-old male, came with complaints of hematuria, fever, left flank pain with history of trauma 1 week back. On examination, his vitals are stable and pallor present. Tenderness in the left flank. Periurethral catheterization showed gross hematuria. And coagulation profile and creatinine are normal. USG abdomen and pelvis done, which showed gross left hydronephrosis with thinning of the renal cortex and 10 mm lower pole calculus. And CECT was done, which showed left gross hydronephrosis with narrowing at the level of PUJ with blood in the pelvic aerial system and thinned out cortex. And left PCN was inserted. We noticed urine with clots. DTP urinogram showed differential function of 43% in the left kidney with GFR of 31. And T half of 22.45 minutes, which showed significant outflow tract obstruction. Left Anderson-Hines pyeloplasty was done after 2 months, which showed adynamic segment at PUJ. Patient is doing well at 3 months follow-up. Coming to the case 2, he is a 13-year-old male, same as the case 1, with right flank pain with gross hematuria and history of trivial trauma. On examination, vitals are stable and tenderness in the right lumbar region. Periurethral catheterization showed gross hematuria. HB was 5.6 at that time. Packed red blood cells were transfused and coagulation profile were normal. Creatinine is 0.8. And CT scan of the abdomen and pelvis showed blood in the right renal pelvis. Thinking that this patient may land up in complications, we went with the right PCN, which showed gross hematuria and it resolved in a week. Right nephrostogram showed dilated pelvis with PUJO. He was planned for the right pyeloplasty. Meanwhile, he presented to the casualty after 2 weeks with gross hematuria and hypovolemic shock. In spite of adequate resuscitative efforts, he succumbed to death. Coming to discussion, initial evaluation in a patient with renal trauma is to assess the hemodynamic status. Diagnosis is by CT abdomen and pelvis. The main management of the renal trauma is to stop the bleeding, maintain nephron function and to reduce the complication rates. Non-operative management is done by close monitoring and bed rest. Minimally invasive techniques include degestenting, PCN insertion or angioembolization as indicated. To conclude, gross hematuria following seemingly trivial trauma should arouse a suspicion of pre-existing renal lesions like hydronephrosis, cyst, tumor, abnormal kidney position. Management in this population does not confine to the guidelines of a renal trauma, and clinical judgment plays an important role in determining the best therapy for this patient.
When even in the first patient, why was a PCN put in any of these cases?
Sir, actually this patient had the fever spikes, so went on with the PCN in this
You
case,
did
in the
mention
first
PCN.
case.
Second case,
Sir, second case, as the patient is having blood in the renal pelvis, thinking that he may land up in complications.
what complication you expect?
Sir, he may have the infection of the PCS and
More
that-
likely to have an infection if you put a PCN. And second, point number 2, why if the hemoglobin was 5.6, did you do it? No, I want to see that, please. Put it back. Put the image back.
The previous presentation.
Was there CCT done in the second case? It looks like NCCT to me.
Yes, sir, it was NCCT. CECT was not done at that time.
What are the guidelines say when you have a child with the blunt trauma abdomen? What is the indication? What is the preferred mode of imaging?
CECT, sir.
Why wasn't CCT done here? Because now you have said the patient presented after discharge to the casualty 2 weeks gross hematuria and he succumbed. So it's not how a common renal trauma will proceed. So what do you feel was the cause of the shock and then subsequent death?
Sir, probably at that time the patient had the infection after maybe after the nephrostogram we prescribed the antibiotics. Maybe the patient may not have taken the antibiotics. So we thought that may
So
have led to the
antibiotic
infection.
is an excuse for now. Antibiotic is a treatment of choice for obstructed PCL or I don't think. But anyway,
Majority of the renal traumas have to be managed conservatively. The closed injury, need to wait for it to settle and then manage further. And when did you do a DTPS scan in the first case? You
Uh,
have a,
Sir, in the first case we did the DTPS scan after 1 month, sir.
for 1 month.
After 1 month.
Immediately in a shattered kidney, for DTP
No,
doesn't
no,
achieve anything.
Yes, sir.
I feel management of a PCA obstruction in a shattered kidney, just wait till it resolves and then for any.
Yes, sir.
Thank you. Next call upon Dr. Pavan Kumar from NIMS presenting a rare case of primary TCC of prostate.
Good morning, everyone. I'm presenting a case on a rare case of primary prostatic TCC. We had a 61-year-old gentleman who presented with complaints of obstructive LEDs since 7 to 8 months. He had no significant past history, and his general physical examination per abdomen was normal. And DRE revealed grade 2 prostatomegaly, firm in consistency, no nodules. we went ahead with lab investigations. Hemoglobin revealed 10.2, creatinine was 1.3, and CV revealed 2 to 3 cells, RBCs per high power field. PSA was 12.19, and UFR showed 210 voided volume. Qmax was 8.5, and average flow was 3.5 ml. And we did a scopy, pre-op scopy, showed grade 3 lateral lobes, and bilateral ureteric orifices were normal, visualized, and bladder, neck, and urethra was normal. USG showed bilateral kidneys normal, prostate size of 52 cc, and pre-void 380 cc, post-void 50 cc. So with this background information, we went ahead with TURP, and histopathological examination revealed high-grade urothelial carcinoma. So we kept the patient in follow-up and asked him to get a CCT abdomen done, which showed evidence of a large hypotenuse lesion measuring 18 to 7 centimeters arising from prostate with a heterogeneous post-contrast enhancement. So we also got a PET CT done, which showed metabolically active, locally advanced primary in prostate and no evidence of mets. So we referred him for medical oncology, wherein he received 3 cycles of gemcitabine and cisplatin regimen. Then post NACT, the repeat PET scan was showing resolution of the lesion, and we subjected the patient for cystoprostatectomy. Sir, around 1 month later he had to come, sir. Yes, sir. But we did not know what was the size before he underwent. Sir, IHC markers were showing serum this PSA was negative, and it was more in favor of urothelial carcinoma. We had actually consulted a pathologist as well, sir, to review the slides. We were in confusion whether it is a prostatic thing or a urethral malignancy. So we reviewed the slides with the pathologist, wherein they confirmed it was the TURP chips showed no benign hyperplastic changes. There was only neoplastic cells. So there was also a component of ductal invasion.
Have you done bladder mapping biopsies? Bladder biopsy.
No, sir, there was.
Do you remove bladder? Radical prostatectomy. No? You have not done a bladder biopsy.
Yes, sir.
Don't know whether any case changes are there in the bladder. Then radical.
But as the report of HP was revealing urothelial.
Okay, fine. Then don't remove it. Urothelium is present in the ureter also. Both ureters are lined by urothelium. Ureters. Hysterectomy was not indicated. You have just done a radical prostatectomy of the patient by check scopies.
Do you think that 8 centimeters lesion, the prostate, and DRE being normal, is it complementary or what? Why the findings are different?
Unlikely, sir. Even it was to our surprise that we had such a finding.
Yeah, rectal examination, you said grade 2 prostatomegaly form. So it is not favor of a
yes, sir.
BPH.
Yes, sir. That is.
Is it not? And the PSA was 12.
Yes, sir.
Does it need a biopsy, prostatic biopsy initially before you go? 12 physical findings like a form, prostate,
That did
suspicion.
not prompt us to get a biopsy, sir. There was no nodule or. There was no DRE nodule or hard inconsistency.
Not necessary, no.
What are the indications of prostate biopsy is what sir wants to say. Very clear. Your clinical suspicion, a DRE, you should have a PSA about 10 is a mandatory for prostate biopsy.
About 10.
A known phenomena that anywhere TCC, if you resect and you don't have a R0 resection, tends to grow very fast. Probably that is the reason for your initial 50 prostate that has grown to 8 into 10 centimeters.
Yes, sir.
So whenever TCC is touched, don't do an R0 dissection, it tends to grow.
Thank you.
Thank you.
I next call upon Dr. B. Jawhar from Yashoda Somajigoda, presenting augmented anastomotic erythroplasty in 31-year-old male patient.
Good morning, everyone. My case is a 31-year-old African male, came with complaints of poor stream and straining to void since 6 months. No history of dysuria or other lower urinary tract symptoms. No history of constipation and hematuria. No comorbids. Examination, abdomen is normal. External genitalia, penis is circumcised. EUM is normal. Bilateral testis normal. DRE tone normal and prostate is flat. Pre-op UFR is done, which showed a Qmax of 5.5 and voided volume is 154 ml and CU is within normal limits. RGU is shown in the left upper corner, which is showing a short segment stricture at the mid-bulbar urethra. The right upper hand is a urethroscopic view of the stricture, which is a dense stricture, approximately of 2 centimeters in length. And the left lower picture is we have done a augmented anastomotic urethroplasty under spinal anesthesia, and after opening the perineum is incised in the midline, and then after identifying the urethra, we have circumferentially mobilized the urethra around the stricture length, and we have completely excised the stricture part, and the urethra is spatulated dorsally, both proximally and distally, and we have harvested a 4 into 2 centimeter 2 centimeter buccal mucosal graft from the left cheek under local anesthesia. Graft is defatted, meshed, and the graft is placed dorsally, and the ventral spatulated urethra is anastomosed using a 4-0 rapid vicryl. You can see the ventral spatulated ends of the normal urethra on the right lower image, and the completed ventral anastomosis on the left lower side of the slide. So conclusion is the complete excision of abnormal urethral mucosa is prime importance, and spongiofibrosis and a tension-free anastomosis is more important, and for achieving good results. Augmented anastomotic urethroplasty provides good results in short bulbar urethral strictures, which cannot be treated with primary anastomosis. Thank you.
So if you look at the RGU, and so you mean to say that the findings in RGU, operative findings,
They are deceptive. The RGU finding is showing a short segment stricture, but when we did a urethroscopy, it was around 2 centimeter length, and it was very dense. So patient wanted a long-term relief. So we have planned for a BMG urethroplasty straight away without going for an IU.
mean to say that RGUs most of the times they are deceptive. What is the chance of underestimation or overestimation of the length of stricture in RGU? Studies on
The
We generally use vicryl, that rapid vicryl.
young male, 31, is he married? Has he completed his family? And were there any alternate just told to you directly you planned for anastomotic?
No,
What
sir.
was
We
the
have.
approach? You did a midline incision, whether it was a bulb preserving one or
It was a bulb preserving one. We reflected the bulbocavernosus.
lateral dorsal approach only.
Yes,
You
sir.
have dismembered the urethra there.
Yes, sir.
One more question. What are the maneuvers you have mentioned in the
Yes, sir.
conclusion to prevent bulbourethral. What are the maneuvers,
Maneuvers, yes, sir.
in your case performed to prevent bulbourethral necrosis?
We have mobilized the urethra around 2 centimeters proximal and distally to the stricture part, and that was sufficient to gain the ventral urethral length. Other options would be crural suppression and inferior pubectomy if the length. In this case, we did only a urethral mobilization that was sufficient.
That is only for when you have a posterolateral distraction defect. And in this case, actually, it will not help because the curve of the bulbourethra is more or less maintained here. You are not going to get any extra length with those. This is not a progressive perineal approach. You don't need in this. Sort of a mid bulbar. You do not need to do any progressive perineal approach. You don't need to do crural suppression. You won't get any extra length.
Yes, sir. We are not done in this
See,
case.
it's the when you have a posterolateral distraction defect, that curve is not there. You see the curve, the proximal curve, that urethra will not be there. So you need to bridge that with it's like the third side of a triangle. You need to bridge that as the hypotenuse. In this particular case, that curve is there. As long as there is normal urethral curve proximally, you can see the dilated urethra there. You will not gain any length with a crural separation or a pubectomy.
Thank you.
Just one comment. See, it is almost a distal or stricture. So our blood supply is well maintained with the bulbar arteries. We are not disturbing it. That is, I mean, can be stretched 1 centimeters, absolutely. Yeah, unlikely. Never happens here because we are not touching the bulbar arteries. Retrograde blood flow is not good, then it happens.
Thank you.
Thank you, sir.
I next call upon Dr. R.K. Rajesh from Apollo Jubilee Hills, presenting three-dimensional reconstruction of renal vascular tumor anatomy to facilitate accurate preoperative planning of.
Dr. Rajesh is absent.
Next, Dr. Pawan Kumar from NRI Medical College.
Very good morning to all. Today I am going to present a case series on 5 cases where we have operated ureter. Coming to the introduction, urethral avulsion is probably the most catastrophic complication of ureteroscopy and most often occurs during ureteroscopic stone retrieval. Coming to the case series presentation, a total of 5 patients we have received ileal ureteric replacement in the duration of last 5 years in our institute. Out of them, 4 cases were due to ureteric avulsion referred to our institute, and 1 case is of genitourinary tuberculosis with multiple ureteric strictures and functioning kidney. The case profile of the 5 cases where we have done ileal ureteric replacement. And out of the 5 patients, 2 patients had renal insufficiency. Preoperatively, we managed the patients with percutaneous nephrostomy tube, where the creatinine levels were around 2 creatinine. And these patients showed improved or stable functions post reconstruction of the ileal ureter. And coming to the discussion, depending on the length and position of the ureteral injury, erythroitrostomy, SOGUS', and Boeri flap and autotransplantation can be used in alternative techniques for treatment where commonly used. And all of these techniques have an inherent limitations owing to restricted availability of the ureter or bladder, especially in the ureteric avulsion cases. And in such cases, ileal ureter is the only probable surgery we have to do. Ileal ureter was initially described for tubercular obstruction. In recent decades, its indications have been broadened. And coming to my conclusion, ileal ureter replacement is a choice of surgery in long segment ureteric strictures or avulsions. As such, it is a better alternative than nephrectomy in the cases of complex and multiple ureteric strictures.
Dr. Pawan, so some cases you have described of avulsion. So, did you go ahead and do ileal replacement that time, or
No,
you did it?
out of the 4 cases was referred to us, sir. 3 cases was referred to us after within 1 week, and 1 case was referred to us after 3 months, sir.
They all were referred to you.
Referred to us, sir.
So any other method is there where, you know, sometimes the whole of the ureter length is lost, and when you take the whole ileum, you know, the mesentery keeps it. You have to take a long distance, long length of the ileum. Are there any methods, other method described?
Sir,
where you can,
there are certain principles are there, sir. Angdi.
have you heard about Yang-Monty procedure?
Yang-Monty, that's
cell procedure.
yes, sir. Yang-Monty, but all the cases we have deal here are very long ureteric. Yes, sir.
So to be precise, Yang-Monty can be used for whole length.
No, sir. Not for whole length, sir.
Definitely it can be used. I have a series of 13 cases.
I have no.
So you can use from pelvis, reimplant into the bladder. The advantage is it gives a straight tube.
Okay.
In ileal replacement, when you have the ileum will be curved.
Okay.
So it sometimes it is difficult to put the implant, and you have to have a tortuous ileum which comes. That adds on.
I don't.
Anything else?
Strictures. Whatever reason for long segment strictures. The fact that 4 of your cases, 80% of your cases were due to avulsion. The important message going around that more and more RIRS is being done, and therefore the incidence of avulsion is far more. Now, that's the important thing, and the lesson could be, one of the messages you could have put is that you definitely need to pre-stent sometimes when you have a tight ureter and not go ahead. That is one. The second point, just going ahead with what Dr. Vipin said, the ileum has an inherent thing, it's curved because of its mesentery. Sometimes you take a longer segment of ileum, you don't always get a longer length because the limitation is the mesentery.
Okay.
So that's something you don't need to take a too longer length or not too shorter length. You need to take an appropriate length.
All 4 cases were due to ureteroscopy.
No, sir. We have done 3 cases in the last 2
you
years.
told 4 requests referred. What was the cause for
stone? You are 3 cases were URSL, 1 case was RIRS, sir.
they send you with the PCN?
With 2 cases they have sent with PCN, sir. Within 3 days they have sent us. Other 2 cases they are not. 1 case was 1 month later. They have not put PCN. Patient was creatinine was around 4. We put PCN and we may stabilize the patient and we operate later.
Cause for 4 creatine?
Due to dysfunction, opposite side kidneys also have stone, sir. Yes, that. No, we stabilize the patient, sir, with which. Yes, sir. Yes. So we wait, sir.
Thank you.
Hello.
Anybody?
We have got our own series from PGI where a long total segment replacement of the ureter could be done with a bladder. So we published that earlier, and it was a vesicopelvic anastomosis with different maneuvers, psoas hinge, and a long flap taken from the opposite ureter. This is possible only in few cases where the bladder capacity is more than 600 to 800.
Absolutely, sir. We have got 2 cases.
There is one more alternative.
We have got 2 cases where if the filled bladder capacity on a cystogram reaches the pelvic brim, you have seen that 15 centimeters of the bridge of the ureter can be.
You should go beyond the pelvic brim. Roughly about 800 liter.
Yes, sir.
Is a good method. Sure shot to go for that.
And you don't feel you need to utilize the bowel segment.
Yes.
That's a very good option.
That's a good option because you maintain the transitional mucosa to mucosa.
That's one thing. Second thing, if you are not able to reach the pelvis, you can do as well a ureter chalicostomy or cystochalicostomy.
Yes, sir. You can do a cystochalicostomy. Thank you.
Thank you. Next, I call upon Dr. Sandeep Kumar Reddy from Narayana Medical College, presenting a rare case of leiomyoma of urinary bladder presented with obstructive uropathy.
Sir, good morning all, sir. My case is a rare case of leiomyoma, sir. of urinary bladder presenting as obstructive uropathy. 44-year-old woman, sir, presented with gross hematuria, increased urinary frequency, sensation of incomplete emptying and left loin pain, sir. Serum creat was 4.2 and complete urine examination revealed macroscopic hematuria and pyuria, sir. Pelvic examination revealed bimanual examination revealed a mass on the left side, sir, near the bladder neck area. We did ultrasound. Ultrasound revealed a 5.5 into 5 centimeter smooth lesion, sir, with peripheral hyperechoicity arising from the base of the bladder near the left VUJ. Patient has left moderate hydroureteronephrosis and right mild hydronephrosis, sir. We did CT scan plain KUB, which showed well-defined heterogeneous hypodense mass lesion of size approximately 57 into 54 sir, noted in the lumen of the urinary bladder, arising from the base of the bladder at the site of BUJ with left moderate hydroureteronephrosis and right mild hydronephrosis. We did cystoscopy examination, sir. There was a 6 into 5 centimeter endovesical tumor was arising from the base of the bladder near left VUJ, and bilateral double degestion we placed, sir, for the obstructive uropathy. After 2 weeks, we again re-evaluated, sir. Once creat came down to 0.9, we took few chips, sir, during TRBT and sent for histopathology, sir. Histopathology showed intersecting fascials of spindle fibers with elongated nuclei that were separated by connective tissue with occasional focus of necrosis and no mitotic activity and cellular atopia was there, sir. We sent for ISC markers. ISC markers are negative for Ki67, sir, Ki67. They are positive for actin and H. caldosinum. Then later we planned for surgical resection, sir, after 2 more weeks. We did lower midline incision. We opened the anterior wall of the bladder. And since it's endovesical tumor of size approximately arranged from the base near the VUJ with a normal mucosa over it, we excised completely, sir. On the histopathology, it showed leiomyoma, sir, pathological diagnosis of the exert tumor of leiomyoma. Post-op patient was uneventful, sir. Discharge on 1 week later and patient doing on follow-up. Conclusion, leioma is a rare, uncommon benign tumor. Thorough history, physical examination is needed. Using CT, ultrasound, we can determine the location and local extension. It can be endovesical, intramural or extramural. Surgical resection with wide enough is adequate, sir, because its recurrence rate is low and with no symptoms. It has excellent prognosis, sir, because of the benign nature.
What was the reason for hydroureteronephrosis and obstructive uropathy in an intraluminal thing which is not obstructing the ureter?
It was exactly near the almost near the base of the bladder, sir. Exactly like patient has his obstructive symptoms, sir, because it was almost like bladder outlet obstruction. Sir.
Absolutely, it
Yes,
was a
sir.
bladder outlet obstruction rather
sir.
not the ureteric obstruction.
Yes,
That was
sir.
the reason.
Yes, sir.
So stenting was not required, rather ureteric catheterization at the time of surgery was required. Just putting a catheter would have decreased obstructive uropathy in this.
Yes, sir. Yes, sir. Like no, sir. We did primary excision, sir. First we reduced the creatinine, sir, because patient has obstructive uropathy. We reduced the creatinine by keeping stents. After that, we sent for the we took chips, sir. We sent for the histopathology. We did the ISC markers also, sir. It was negative for leiomyosarcoma. Then we did the primary excision, sir. The open primary excision.
Tumor is very close to the UV.
It was near the base of the bladder of the left VUJ, sir. Near.
Could manage without.
Sir, yes, sir. Without. Sir, the patient has hematuria, sir. We didn't attempt it. It was vascular tumor. Stents. Both stents and Foley, sir. We kept everything, sir.
Was there any history of previous surgery for this patient?
No, sir. No surgery. Previous
Because there
history.
is
No.
something known as parasitic fibroids.
Okay,
Patient
sir.
has a history of fibroid excision from the uterus,
Sir.
known as parasitic fibroids that grow into the bladder also.
Okay, sir.
The questions? Thank you so much.
Thank you so much, sir.
I thank Dr. Bipin, Dr. Mohsen, and Dr. Mohammed Gauss for sharing the session. And I request Dr. A.V. Ravikumar, sir, to please come and present mementos to the chairpersons. Dr. Surya Prakash. Okay, sir. Right, sir. So the next topic is on a program on urethroplasty, cell therapy in urethral stricture disease, where we are. And the moderator for this session is Dr. V. Suryaprakash, sir. And I request Dr. P. Vilanmurthy, sir, Dr. K. Sanchari, sir, and Dr. Bhavatej to come onto the dais and chair the session.
Thank you, sir. Thanks, SOGUS, for giving me this opportunity. This is the work which I've done in the last 5 years. Like to, the program will be like this. I'll be giving a talk for about 8 minutes. Then we have case discussions where we have our expert panelists. They'll discuss the case. So we all know stricture disease is a very tough entity to manage. It continues to be a challenge. In spite of having so many procedures which were described many years ago, still we continue to struggle with this problem because of the lack of a perfect procedure. The last 10-15 years, buccal mucosal graft urethroplasty has stood the test of time. Though it has got high success rate, it is a major procedure with significant morbidity. So there have been many advances in the last, I can say, 10 years. These advances are in the field of regenerative medicine and tissue engineering. The main focus is on decreasing the recurrence of stricture after VAU and constructing tissue engineered urethras. Can we construct the urethra? Can we make the urethra in the laboratory? That is the question. So how can we improve the outcomes of VAU? So there have been many studies, like people have injected some drugs. They've injected hyaluronic acid after VAU thinking that it will reduce the recurrence. They have used drug-coated balloons, thinking again that it will reduce the recurrence. Even they've used PRPs, do a VAU and inject PRPs as mesenchymal stem cells. So many things have been done in the process of reducing the recurrence of the stricture. So the other aspect is tissue engineered urethra. So what we have tried is epithelial cell-seeded grafts. You take the cells, culture in the laboratory, mix them with the scaffold, and then inject the cells endoscopically after an incision. This is one way of managing. That's one way of engineering the urethra. The other way is that the extreme. You take the cells, culture in the laboratory, make a sheet of urethra, and then do an open urethroplasty, put the graft. So these are the advances in the last, I can say, 10-15 years. So I'll just go through 2 or 3 studies, which are really landmark studies in the field of tissue engineering. This is from Dmitry Nikolovsky group. What they did was, they took the buccal graft, they minced it in the operation theater, make into small pieces. And basically this was an animal study. They divided rabbits, they created stricture in the rabbit with using electrocautery, divided the rabbits into 2 groups. One group, they did a VIU and injected this minced graft with fibrin glue. And the second group, they did a VIU and just only gave fibrin glue. So what they found was, the rabbits which were injected with minced graft or liquid buccal mucosal graft, they did well compared to the rabbits which were even only fibrin glue. But it's a very small study, animal study. They could not continue with the clinical trial because the FDA did not give them approval to use fibrin glue into the urethra after urethrotomy. So that's where the process stopped. So later on, Nikolovsky tried with the liquid mucosal graft, minced graft alone, but his results were not good. And this is another study from India. This is from Dr. Sanjay Kulkarni's group. What they did was, again, the similar concept. They took buccal cells. They called it ALBEC, autologous adult live cultured buccal epithelial cells. Small graft was taken from the patient's inner cheek. Cells were separated, and the cells were cultured in the lab and in a modified Eagles medium, and they did a VAU after some time, after maybe 2 weeks, and then injected the cells. This is marketed by a company by a name called Uric Grow. This was published in World Journal of Urology, and this concept is called ALBEC. Of course, their follow-up was very short, 6 months. What they found was, after doing this study, voided volume increased, AES symptom score decreased, flow time improved, flow time decreased, and maximum flow rate improved. What they found was the flow rate improved from initially from 2 weeks to 12 weeks, and there was no difference up to 24. We don't know what happened after 24 weeks. So the authors conclude that the Albeck implantation of bulbar urethral strictures for 1 to 4 centimeters strictures is effective for a period of 24 weeks. So this is our study. What we did was initially we did an animal study and we published in the Regenerative Therapy the successful engraftment of epithelial cells from the autologous rabbit buccal mucosa encapsulated in a polymer scaffold. What we did was we took a small bit of buccal mucosa from the rabbit cheek, cultured the cells, and then we mixed the cells with a polymer scaffold and then injected into the rabbit urethra. This is how we did. So this is the pictorial representation. We created a stricture using an electrocautery in the rabbit urethra. But then after 2 weeks, we incised the stricture. Then we put a catheter. In that lumen, we injected the cultured buccal epithelial cells. So this is the rabbit oral cavity. A small buccal mucosal tissue was taken. Cells were separated. This is the 2D culture. 2D culture where we did not get a good representation of the cells. Cells were not looking like normal cells. They were looking like fibroblasts. Then they were later cultured in 3D. 3D culture, they had a normal morphology. So this is the urethrogram after we created the stricture, the rabbit urethra stricture. And now we are doing a VAU in the rabbit urethra. So this is the incise, the knife is passed into the urethra and an incision was given. Once the incision is given, a catheter was placed into the rabbit urethra and the cells are injected. This is after around 3 weeks. You see, this is a histopathology section where you could see the implantation of the buccal epithelial cells. They were multi-layered squamous epithelium, which proved that the cells were implanted and they were taken up. So this is again doing the same thing. So then there was some question, are you really sure that they are buccal epithelial cells? We wanted immunohistochemistry. There were some authors, they wanted to prove that they were squamous epithelial cells by doing immunohistochemistry. Later on, we did IHC also in those cells. And this was published in the stem cell reviews and reports. The engraftment of transplanted buccal epithelial cells onto the urethrotomy site proven immunohistochemically in rabbit model, a feat to prevent urethral stricture recurrence. This is, you can see, this is the stricture. After injecting the cells, you can see a good lumen. If it is a squamous epithelium, the marker which has to be positive is CK14. So the CK14 was positive at the site of implantation, whereas the GATA3, which is specific for transitional epithelium, was negative. So this is how we proved that the CK14 positive cells were presented at the site of implantation and saying that the urethra has taken up the squamous epithelium. So then a clinical study was done and it was published in International Journal of Urology. And we call this procedure as Bees-Hawes, buccal epithelium expanded and encapsulated in scaffold, a hybrid approach to urethral stricture. A novel therapy is what a pilot study. Similarly, as in the animal study, we took a small graft of buccal mucosas, separated the cells, cultured them in the lab. Then after 2 weeks, erythrotomy was done for the patient, and the cells which were cultured in the laboratory were brought to the operation theater. These were the cells on the day 0. You can see these are the cultured cells. For 0 to 7 days, you can see these multiple cells which were grown in the laboratory. 10 to 12 days, cell density has increased. So these cells were brought to the laboratory, and after doing a VAU, we injected. These cells were mixed in a scaffold called thermogelation polymer. This polymer has got a reverse physical properties. If you cool it, it becomes liquid. If you heat it, it becomes solid. So the scaffold holds the cells in the urethra so that they get implanted. So this we have done in 6 patients. Here you can see this is the initial harvest of the cells, and these are the final count of the cells which we injected. After the 6 patients, 2 patients had recurrence, and 4 patients are doing well. And one of these patients had a prior buccal mucosal graft urethroplasty, and one patient had prior twice VAU. In the follow-up, the catheter was removed after 3 weeks. All patients voided well with good stream. And in the follow-up, they were assessed by a flowmetry, symptom score, and a check urethroscopy at 1, 6, and 12 months. So this is a urethroscopy at 1 year of follow-up. You can see after injecting the cells in the scaffold, even by doing a urethroscopy, that pink area, these were the cells where the cells were implanted. And we took a biopsy from that site to prove that there are the buccal cells. So in this area, the cells were taken up. And we took a tissue from that site and it found to be a squamous epithelium. And this is the RG of the same patient 1 year after the implantation. They had good lumen and the patient is voiding. So to conclude, to date, cell therapy based procedures such as liquid buccal mucosal grafts, erythroplasty from Dimitri group, and Albec from Dr. Sanjay Kulkarni group have reported positive outcome. But the problem with Albec was they used the Dalbeco Eagles medium, which is a biological material, and the risk of infection and contamination. So that is the main concern with this Albec procedure. The R procedure, the Bees house, is less invasive, uses synthetic scaffold with the efficacy in pilot clinical study with more than 3 years recurrence-free interval. This study, initially we did it as a clinical trial. Then we wanted to do the same thing in Japan. We did not get the permission. Then we did a animal study, rabbit study. Initially we did a histopathological study. Then we confirmed by immunohistochemistry. And we got an approval to do clinical study in Japan. This I did it with a collaboration with an institute called Nichin Center for Regenerative Medicine. Very soon it will come into the clinical practice. First in Japan, then maybe the rest of the world. Thank you.
Well done, Surya Prakash.
Thank you, sir. Sir, yeah.
From his way, means they had made a whole urethra in
Yeah.
laboratory.
In fact, Dr. Barbagli also cultured the urethra. He called it mucocell. So they cultured the cells, made a sheet of the buccal mucosa. But it did not come into, it did only a pilot study. Very, very expensive, the culturing the sheet and making a sheet and bringing it into the laboratory and doing the erythroplasty.
There are two issues with this. This has been there for about Atala. If you look at that paper, 15 children, all from Mexico. There is really no follow-up of that paper.
Yes.
I was there in his center, and even everybody was saying there's no follow-up. 15 children, all from Mexico. The second point is about the scaffolding. The problem is that has been used extensively in Germany. The problem is translation of the lab results into the real clinical scenario. That is where all
Exactly.
this cell therapy has failed, at least in urology. So unless we have something which forms a tube and survives, it would be difficult at this point of time to.
Forming it, initially everybody what started doing, they wanted to make a new urethra. They could not succeed. How the cell therapy came. We do a urethrotomy and inject the cells. This we found it to be, we could get reasonably good results. And initially it was not accepted. Then they asked us to do an animal study. In animal study, we have proven both histologically and immunohistochemically that the cells were taken up.
Prakash, study, when I was in OIC, we had a talk with at that time the same discussion came. There he think I don't exactly remember. I think Lal Malani, right? He was director. So what he was telling was live cells in a scaffold, not fibrotic. That means what you were telling, make an optical hysterectomy and then won't take.
Yes, sir.
The cells will die off. Yeah, the same thing if it were to be live, that means take a healthy, take off the. Then I was asking, what is the reason for that? At that level, any progress that means that's it. Then they can survive. Then the answer is the answer.
Definitely a scaffold is required, sir. Why the other procedures like Nikolavsky procedure, even Dr. Kulkarni's technique, although they published, it has not come into good clinical practice.
Yeah.
We need a scaffold. In our study, we used a scaffold called TGP. It's a liquid. Like if you cool it, it becomes liquid. It acts as a nourishment for the cells also. The cells are mixed with this TGP medium. It's a liquid scaffold. Once you inject the scaffold containing the cells into the urethra, at body temperature, it becomes solid. So it gets stuck to that erythrotomy site, and the cells in the scaffold, they start proliferating. In fact, we have shown that the cells move in the scaffold.
Of the buccal cell, I'm just only a suggestion.
urethra.
Why not we try the urethra itself for the culture? So that,
Buccal mucosal
it is
cells.
more and more
Sorry.
natural, their own environment.
Bladder mucosa can be tried, but not urethra, I think, sir. Bladder mucosa, but it is easy to harvest buccal mucosa. And we took hardly 0.5, 1 centimeter of the buccal mucosa. That's
Because even in the BMG, buccal mucosa, after sometimes, say 5 years, present 10 years, they get replaced. You can try the result, they're doing work. You can make an attempt to use.
urethra may not be option, sir, because again we will traumatizing the urethra. But all we can take a bladder mucosa.
Because bladder mucosa, there are a lot of trials and actually try to.
We don't want to incite another stricture by taking a urethra.
SP, how do you inject this material at the site?
We do a urethrotomy, put a 14 French silicone catheter. Then by the side of that, we put a 17 French cystoscope. Through a 5 French ureteric catheter, we inject the cells. I didn't show you the video.
At the site you inject?
At the site of, we do a wide urethrotomy from 10 o'clock to 2 o'clock. And through the ureteric catheter, we inject the cells. We have to immediately inject because that medium gets solidified very fast. It stays there. So it comes as a very cool, cold liquid. Once you inject, it becomes solid. It gets. That video is not playing.
So it won't get disturbed while you are passing the catheter.
Initially, we place the catheter. Put the catheter, then inject the cells. So now we move on to the next session, next part of this session. That is about case discussions. There we have some interesting cases. We need the opinion from the expert panelists. We have got stalwarts in surgery, Kari sir, Murthy sir, and Bhavtej. I'll show some commonly encountered case scenarios which we routinely see in our practice, what these experts are going to say. The case 1, 40 years male, presented with obstructive LUTs, poor stream straining, there is no comorbidity. Abdomen is normal, but external genitalia there was BXO changes over the glans and the prepuce. Hiatus was narrow, and the ventral surface of the urethra was indurated. You can see this is the picture of the glans and the classical of BXO. The long segment stricture following the entire. Kari sir, what is your plan?
You go back to the RGUs. Now, this is a patient of a young, middle-aged person, 40 years, with an extensive changes of BXO and a long pinobulbar stricture right up to the proximal bulb. We have about 3 centimeters of the proximal bulb nicely dilated. And we see the erythrogram, there is a distended bladder.
And the proximal also is a stricture.
Yeah. So there is a distended bladder. So primarily in such cases, we would do first put a trocar, drain the bladder to clear the infection as well as to have a control on the management of a long panurethral strictures. You mentioned that there was an induration of the urethra.
Yes.
That may mean that is it more like a periurethral, just a periurethral spongiosal fibrosis, or is it a periurethral fibrosis?
Spongiofibrosis.
If it is a spongiosal fibrosis, since it's a pan-bulbar stricture, we can go for a augmented erythroplasty with buccal mucosa.
So you want to put a SPC first and then wait for some time?
Such cases, I'll always put an SPC.
How long do you wait, sir?
Put an SPC, wait for 2 to 3 weeks, and then and repeat the erythrogram or MCU at this stage.
What is the idea, sir? Putting it to reduce the infection or
to stabilize whatever fibrosis that has set in as he is passing urine. It will consolidate by giving some time, a urethral rest. So urethral rest will help us to find out what is the real extent of the stricture before doing it, and it also gives us the an MCU picture, which is also required in management of these complicated strictures.
Will it make your next surgery difficult because urethra may be further narrowed?
It will not. Urethra narrows. That is the purpose of doing an SPC, to see how much urethra narrows on giving rest and how much length of the segment of the urethra that we are going to do erythroplasty. That to know that we should have an SPC. And Anyway, doing the cases on the table, you would anyway give an SPC in the, at the time of buccal mucosal graft. So doing only with single catheter, such patients will be dangerous.
Yeah, this is a panurethral stricture. So including the meatus, you can see that there's a metal stenosis and a small proximal bulbar is spared, very small, maybe 1 or 1.5 centimeters. And there might be another, please go to the urethra. Bulbomembranous, that proximal, there must be a ring. Anyway, open it, you know that how to extend the. So these cases, what I do is, I do a gradual urethral dilatation pre-op. Lasts for 10 days at least.
You put SPC or no, sir? Do you
No
put
SPC. The same problem, what you think.
There's a
With the
difference of
SPC,
opinion.
there
Okay.
will be complete closure. Some people put the SPC to the rest of the, but these are all burnt out urethra. What you see when you open it, all fibrosis. Entire thing is fibrous. So what I do is on a guide wire, put a 6 French feeding tube. So gradually go up to the 14 French. So before doing an erythroplasty, buccal mucosal graft erythroplasty, I remove the catheter 2-3 days before, do a culture, and if the positive, give specific antibiotics. And I do always a Ashopa technique. Probably it may require about.
We will come to the technique. We will come to the surgery next.
I'm not talking about the technique. May require at least 2 grafts. Buccal mucosal graft.
Of this, do you also practice SPC?
Patient
So there's some difference of, sir, the concept over sir has said is very well described, urethral rest. There is a chapter in one of the textbooks on urethral rest.
Here, I would do it in a 2-stage. I do an SPC. If at all there is the patient is totally obstructed, I would put an SPC.
No, he's not
and
obstructed.
give a ventral ureterotomy and wait
He's not
for.
obstructed.
Yeah, I'll give a ventral ureterotomy and give him a period of steroid. Intraurethral steroid we practice in our institute, and we see after 4 to 6 weeks.
You do an SPC and give intraurethral steroids.
Yes.
What is the protocol? How much
First,
dose?
we give an SPC because you're telling there's an induration. We give an SPC, wait for 2 weeks, following a ventral ureterotomy. Then we
Ventral
take
ureterotomy.
Ventral ureterotomy. That is a meatotomy.
Meatotomy, you mean to say?
Yes.
Okay, okay.
And if possible, in the
Meatotomy
same.
ventrally or dorsally?
Ventrally. We give a ventral ureterotomy because this is a burnt out urethra. Then we give an intraurethral steroid
What
therapy.
steroid?
We give a
Clobetasol.
And we give him, ask him to inject into the urethra.
Ointment.
It's an ointment, not a cream. It's an ointment based. And we wait for 4 to 6 weeks. Let the
How
induration
frequently you inject? You tell the patient or you inject by
twice
yourself?
a day. Twice a day. Once in
teach
the
the
morning
patient?
and once in the night. We teach them.
How much? Inject the entire tube or how much?
We ask them to inject with that. We ask them to push it into the urethra and calibrate with the 12 French Nelaton or a 10 French feeding tube, so that it goes in. And overnight, in the night also, we ask them to do it. So just keep it for 4 to 6 weeks and then plan.
Have you seen any difference with steroids, without steroids?
Yes, with steroid, what happens is the urethra becomes little supple. And if he's not able to do it, then we go ahead and do the procedure.
Healing also may get impaired.
It becomes supple.
Supple, I agreed. But the healing also may get impaired.
Then during the procedure, it becomes easy while dissecting the penile urethra from the corporal bodies.
I think it's
Separation.
worth publishing. The results are good, I think.
Yeah, we are waiting for the 5-year results, not early before that. There's no point publishing. We don't have a 5 years follow-up, at least.
Sir, Chari sir, treatment plan.
Yeah, once you have done SPC and then had cultures and then you're ready for surgery, I will do a dorsal one-sided Kulkarni's technique.
Those days where buccal
And
mucosal graft
there is
was-
one segment which is very narrow
Yeah.
in the distal mid bulb. That may have to be seen on the table and then addressed accordingly.
So you will do a buccal mucosal graft urethral.
Yes.
So those days you were doing this 2-stage Johansson's lay open. Are those concepts are gone nowadays, or you still practice?
No, that's still followed. That's not stopped. Whenever there is a problem after a buccal mucosal graft, then I would go for a 2-stage.
So for this case,
For a primary also, if there are, it's not just a spongiosal fibrosis, it's a periurethral fibrosis. Then I would go for a 2-stage.
So you lay open the urethra.
Lay open the
Do a
urethra,
perineal
put a
ureterostomy.
perineal flap,
The
the Blandy stage 1 combined technique, and then
after 3 months again
and if
tubularize.
after 3 months I will go for a
With a buccal graft or without buccal graft?
with
also?
buccal graft.
With
With buccal
dorsally.
graft. It needs a buccal graft because there's a lot of scarring there.
Yes, sir.
In some of the cases where you find lot of infection ulceration, couple of cases I did a 2-stage buccal mucous graft urethroplasty.
That's what I put that also. 2 stage.
You laid open entire urethra and wait for about 3 months, then give a ventral dorsal urethrotomy, put the buccal mucous graft and close the urethra.
That's what.
That is a 2-stage.
So all of you will agree on single stage or any difference of opinion? 2 stage.
Single stage. The problem with the 2 stages, when you lay open the EXO or the lichen sclerosis patient, the surrounding skin also tends to have this changes of BXO.
Correct.
So to prevent that, we tend to do it in a single stage and leave the distal penile segment or meatus. Don't go up to the meatus and reconstruct the meatus. Leave it open so that in the post-operative period, he doesn't have turbulence at the meatus. The failure occurs at 2 places. One is at the proximal and distal segment and in the junctional stricture. These are 3 areas where you tend to get recurrence. So you should not have, you should be very proximal. The segment should be treated well. You can lay open the distal segment and leave it. You can do it later at the later stage. So the distal segment should have less turbulence, especially in these cases.
So if the urethra is very narrow, when do you decide that I'll put 1 graft or I'll put 2 grafts both dorsally and ventrally? In this case, do you feel that grafts?
The 2 grafts we have to take in this case.
No, I mean to say both dorsally and ventrally.
Dorsally and ventrally, double face, most of this time we prefer to do only dorsal only. It's a short, it's only dorsal on, not double face.
Cases like this with a pan long urethral strictures, double face will be not good. Because when you want to do a double face and a long graft, it's better to stage it in 2 stages.
Very narrow.
Either a single stage Kulkarni technique. If it is a very short segment, less than 5 centimeters, then maybe you can go for a double face.
The message is for such long segment stricture. Again, there is a difference of opinion among the panelists about the pre-op SPC. The single stage buccal mucosal graft, dorsal only.
One point here to mention is that, as Bhavtesh said, we should not correct the reconstruction up to the meatus. You should always leave a very wide 30 French meatus.
If the meatus is very narrow, stenosed.
You have to go a dorsal metatomy and then put a graft only up to the pinoscrotal junction, up to the coronal sulcus, not go up to the tip of the glans.
Yes,
again, it will again stenose.
What I mentioned in one of my articles, the meatal problems are well addressed in Ashoka because we wide open the meat. Cases like this where it is completely closed, you can wide open up to 2.5
Put a graft.
and get the graft up to that. Meatal problems are well addressed in Ashoka.
I think Sir has already spoke about the pre-op dilatation. Sir, you said how many days you take to reach to 14 French pre-op dilatation?
It takes at least 10 days.
10 days. This is done on OPD basis or inpatient?
OPD basis. Fix the catheter with skin pin.
So this patient, as already experts told, we did a long segment dorsal onlay buccal mucosal graft urethroplasty. What is your post-op protocol, Chari sir?
Postoperatively, we retain the catheter for about 3 weeks, and then 3 to 4 weeks, and then keep the SPC if it is there. Not all patients will have SPC if it is there.
When do you remove the catheter?
For 3 weeks.
Any pericatheter RGU you do?
No, we don't do pericatheter RGU. Most probably there will be no problem. If there is any doubt, we do an RGU afterwards.
I think all of you agree on that. How do you follow up this patient?
We follow them on a uroflowmetry at 3rd month, 6 months, and then just calibrate them at the end of 6 months and at the end of 1 year. And follow them with yearly uroflowmetry or with symptoms or AES course subsequently.
Patients have to be followed up lifelong.
It has to be followed for lifelong.
So this is this RGO of the patient pre-op, and this is a 3 years post-op RGO. So now we go to the second case. 50-year-old male. He's a beta
One
alert
point,
and
SP, one point.
sir.
Yeah, we look at the follow-up symptoms and uroflowmetry. Of late, people are suggesting uroflowmetry alone is not enough. You have to do a erythrogram.
Correct.
maybe after
Calibration is
another
what
3
said.
months, or
Calibration.
calibrate, soft
Calibration.
calibration. That is essential.
This patient is a mature. He's got a the external genitalia were normal. There was no BXO. Oral cavity was very bad. Could not open the mouth completely. You can see, and this is the RGO. What is the treatment? Murthy sir.
Yeah, there is a distal bulbar pinoscrotal area. There is a very narrow stricture, maybe about 3-4 centimeters. This one. So since we cannot use the buccal mucosa, we have to think of other tissue transfer like prepuce is okay.
This is okay.
Yeah, we can use inner prepuce as a graft. One
Graft or flap? Which one you prefer?
graft will do in this. Okay. Suppose in case flap means, then you can do a Varandi flap in this.
Okay.
Or transverse island flap.
Okay.
You can do.
What about lingual mucosa?
Yeah, that also can be tried. That is one of the options.
Of this, what do you choose?
First prefer a graft, preputial free graft, or if once I lay open the urethra, I can take a decision. If very fibrous plate, then I'll use a skin flap. Otherwise, I would use a preputial free graft.
Skin flap.
Skin flap, it would be a preputial asopa based flap. Preputial.
You have to rotate.
Yes, it will come to there. But Orandi will not come because it is going proximally.
It's going up distal bulb.
But still, Orandi will be difficult. You can't mobilize a Orandi to the perineum. It is only a lateral. You can just mobilize it laterally.
You see, we could get the Orandi flap down after the distal.
Difficult. So it will get devascularized sometimes.
The Orandi flap which we have taken. It was laid open.
Yeah. Scrotal junction, it will get distal sometimes.
Flap. Up to the area.
Second thing is the hairy area will be there. So that's also one problem.
Patient now is on almost, I can say, 7 years follow-up.
7 years.
7 years. We'll go more on to the third case. 10-year-old male, road traffic accident 10 years ago, sustained pelvic fracture urethral injury, underwent a progressive perineal urethroplasty 3 months after the accident, had a recurrence of the stricture, he could not void. Again, the re-SPC was done and he's on SPC for the last 10 years. Sir Chari sir, how will you evaluate this patient?
Yeah, he has a progressive erythroplasty failure following a trauma. So naturally, we will, since he is in obstructive LUTS, we will go for erythrogram.
Yes, sir.
After urine culture, and then we'll assess him.
Will I need to assess the stricture? Sexual function also need to.
Yeah, we'll assess his continence, sexual function, voiding function, and then take a decision.
Bladder capacity because he's been on SPC for the last 10 years.
Yes, sir. He has been SPC for 10 years, yes.
This is the erythrogram. Only pineal urethra is seen.
Erythrogram shows almost the little bit of distal bulb, but most of the bulb has gone. And MCU does not fill the urethra.
Yes, proximal urethra.
So first we'll have to assess what is the proximal extent of the stricture by doing, she is also on a SPC for more than 10 years. So any for stones inside the bladder. So do an antegrade cystoscopy.
Done. The antegrade and retrograde. It cut off at the distal bulb. Bladder was okay. Capacity
But the classical picture of the erythrogram shows it's a bulbar necrosis.
Bulbar.
Yes. So that's why it has failed in the first instance. And the treatment options for bulbar necrosis, what is the age you said?
30 years.
30 years. He has got a good prepuce. Ideally is to take a preputial flap tubed erythroplasty. Don't mobilize the pinobulbar segment more than 5 mm or 6 mm just to take the bites. And then put a bougie antegradely, dissect nicely the proximal stump, invert the mucosa on both sides, and interpose this skin tube in between with a suture line dorsal, and make a good anastomosis over a silicone tube, and leave the catheter for 4 weeks, 4 to 6 weeks.
Full of bowel, sir. Bowel interposition. Have you? The other technical drawback, if the prepuce is not good, then you can do it at the two stage. Put the scrotum and make
Turner
the
Warwick drop back would be tried. But the main problem with that will be the hair,
hair.
and it's a menace.
Bhavtesh, agree with
Prepucial tube in the first sitting and later bowel interposition. Total drawback.
so this is
much
what we did.
experience.
You can see the bulbar urethra entirely is fibrosed. I mean, there's a callus around the bulbar urethra. Urethra from here to here is normal. From here, from this line, you can see it's all like a fibrotic cord-like thing. So it was completed. So this is the proximal urethral mobilization. A lot of callus was there. It was all like, and the stage features you can see nice the mucosa.
The failure, sometimes failures generally occur because of inadequate inferior pubectomy, one, and there is tension at the penoscrotal junction of the bulbar segment. You tend to, and incomplete or crural separation. These are the two maneuvers. If you have done adequately, I don't think so. In the first instance, you will have good anastomosis. But if these two are inadequately performed, then you will tend to have bulbar urethral necrosis.
As Chari sir has said, we took a prepucial flap. You can see the flap was taken and made a tube with the flap. About 7 centimeters prepucial tube was brought into the perineum. Proximal anastomosis is being done. Prepucial tube for bulbar urethral necrosis. We took a momentum because there was a lot of raw area, a lot of callus was excised. So we made a lower abdominal incision, brought the momentum from the abdomen into the perineum, and momentum was put around the. Nearly, I think 3 years now. Patient is doing well. He's got a good flow. He did not require any intervention.
How did you bring it to the perineum? You didn't do.
From behind the
pubis, you made with the forceps.
Because we did a pubectomy, so he could easily go.
You could easily penetrate the diaphragm.
Murthy sir, any comments on this?
Yeah, this is patient is under my follow-up. He's doing very well. I think the latest, this one is also peak flow. About a few days back, we did uroflowmetry. It doesn't have any symptoms, obstruction, or doesn't have any urinary tract infection during these 3 years. Of course, the sexual I did not ask. His flow is, peak flow is about 18 to max, and average is around 10 or.
Is asymptomatic.
No, asymptomatic and no residual. Doing very well. This is the patient I thought with the calibration or a scoping, because these patients tend to get slowly wrapped. The skin is going for stenosis.
We'll move on to the next case. 6-year-old male voiding glass. The main complaint was post-void dribbling. So we did an RGU. This is the RGU. Bhavtesh.
The history of trauma was there.
No history of trauma. No history. He's a young male, is a software guy. His main complaint was post-void dribbling.
If the distal segment is not negotiating with the 17 French scope, then can plan. Problem is it's a distal segment, so we need to be very careful because the tissue surrounding it also is a disease segment. So we have to be careful, try to do it as a ventral approach and do a ventral ASOPA technique.
ASOPA?
ASOPA technique.
It's basically a diverticulum.
Yes, sir. Exercise the diverticulum and repair it by a dorsal inlay technique. Graft. That would
Dorsal
be
graft.
Dorsal inlay graft.
Diverticulum arising from the ventral surface.
Yes, sir. We can
And
exercise
show the cystoscopic view.
Yes, sir.
Urethra is wide open, it's a wide mouth diverticulum. This is the diverticulum. This is the urethral opening.
This is a ordinary urethral diverticulum. Maximum they can have a lip of the valve distally, which has to be looked into. Anteurethral valve is the most probably the cause of such, because there is no history of trauma, no stricture associated with that. So this normally requires a ventral approach. Lay open the sac, size the urethra to the proper diameter of about 20 French, and excise the flaps partially, remove the mucosa, make a tube with a 50 vicryl or PDS, and then double breast the suture line with the fibrous layer.
Can it be managed endoscopically?
I don't think so, because if there is a valve, you incise it, but still the diverticulum will persist.
Exactly, I agree.
And the dribbling will persist.
What we did a perineal approach. You can see the cystoscopy, the brightly glowing diverticulum. This is the diverticulum. You open the diverticulum. What you see? Diverticulum, the catheter is there. It is went in 14 French catheter went in. Or we excise the diverticulum. Then we close the urethra ventrally. We made it around the catheter, closed it. Full breasting, as what sir has said. Flaps of the part of the diverticulum, they were double for the support of the urethra.
Usually the results will be very good. They don't develop a fistula.
And this patient is of nearly 2 years follow-up is doing well. I think this will be the last case. This is a 32-year-old male, poor flow, dribbling of urine. Somebody attempted catheterization, catheter did not go. RGU was lost immediately. This is the RGU. So how will you process? Basically, the thing is you wait or do a repeat RGU, or because we're not able to assess the stricture based on this RGU.
This is a spongiogram because of the mucosal injury of the catheterization or instrumentation. And if he is voiding urine, you have to give him rest for some time.
Okay.
Repeat the erythrogram after 7 to 10 days. After 10 days, you will get the good picture. And then depending on that, we should decide.
7 to 10 days is sufficient. 3 weeks.
Maybe if he is voiding urine, wait longer. Nothing is wrong. Let it heal in 3 weeks. It will heal nicely. 2 to 3 weeks, no problem.
Any role of SPC?
If he is voiding normally without any bladder distension, there is no role. Usually they don't develop bacteremia. If he has not developed within 48 hours, you can leave him alone.
Sepsis is one thing we have to keep in mind.
Yeah, sepsis has to be kept in mind. Correct.
Avdesh?
First of all, message here is that whenever you have an attempted catheterization and it has failed, don't do any imaging procedure. So, and if he's having a problem in voiding,
Particularly when there is hematuria.
yes, with an hematuria, just put an SPC or a simple trocar SPC and drain his symptom, the main complaints which he has come if there is a retention. By doing an RGO, you are creating a more problematic image damage because of the spongiofibrosis, the intravasation of the contrast into the sponge, then you have a sepsis, immediate sepsis. So the take-home message here is that not to do any RGU or imaging when you have an attempted catheterization which has failed.
You agree with that, Murthy sir? Same.
It's a picture.
If this patient comes to an emergency and in the night, so you will have problem. The best way is to do to put a salvage, just put an SPC.
Yeah.
The catheter.
In night time, it's okay. Suppose if the patient comes with bleeding, nothing, put a parietal catheter generally will not be difficult. And if you are putting a catheter there, then most of the times you see injury at the bulbar urethra. And if you can negotiate that one without any stricture, just this is the most common trauma which you see, failed attempt catheterization because of the retention due to BPH.
Is for the stricture.
For the stricture.
I understand that.
We can't pass a catheter.
Once we pass a catheter, then we had to.
Here a catheterization attempted by a
What the
urologist.
message is, once a urethral injury is there, because of some other thing, not because of SPC, we can always attempt a catheterization.
Expert
Simple.
it's okay.
But for the
benefit
teaching,
of the students, the patient is retention, there is a catheter trauma, bleeding. you have to do
SPC is the
SPC
alternate.
and
Yes. Correct.
then evaluate it after 3 weeks.
correct.
Yeah.
I think we'll come to the end of the session. Thank you very much for the comments. Thank you, sir.
Thank you, Sri Prakash.
Thank you, sir. Thank you, Dr. Srinivas, for the opportunity.
I request Dr. Jairam Reddy sir to come onto the dais and to give mementos to the speakers. Dr. Surya Prakash, Murthy sir, momentous. ఒకటిందా? Dr. Chari sir, Dr. Bhavtej, and the next session is Preeti Urology and Kidney Hospitals debate point counterpoint. And I request moderator Dr. Bhargavardhan Reddy to come over and conduct the program.
Very good morning to all. I'm very thankful to SOGUS for giving me this opportunity to moderate Preeti Urology and Kidney Hospital's point and counterpoint debate. Today we have two topics for this debate. Topic one is these are very two common topics for this debate today. Topic one is initial puncture during PCNL, whether to go by fluoroscopy guidance and ultrasound guidance. I invite Dr. P. Naveen Kumar, Assistant Professor, Usmania Medical College, Hyderabad, and Dr. G. Chandramohan from Anantapur. Please come on to the dais. These are the common indications for PCNL. The creation of percutaneous tract into the renal collecting system is the most important step. If you have a good puncture, your off job was done. And all urologists will love to do the puncture of the kidney. And this step usually requires imaging like fluoroscopy, ultrasound, CT guided. Like there are certain advantages and disadvantages for each of the procedure. Our main aim of puncture is to get clear urine. You have to go through the fornix. You have less blood vessel injury. If you go through the infundibulum, you have major vessels like interlobar vessels. And if you have gone medially through the entry into the pelvis, there are chances of injury to the major vessels of the kidney. So now I invite Dr. Naveen to present his views about the fluoroscopic guidance function.
Morning all. Today my topic is fluorogated renal access, the PCNL. I divided my topic into a few subheadings like indications of PCNL in brief, and techniques of fluorogated renal access, and advantages of the fluorogated puncture, and ECIRS, that is endoscopic combined intrarenal surgery, and how to minimize and overcome the radiation effects of the fluoroscopy. As per the European Association of Urology, the following are the indications.
large stone burden more than 2 centimeters, tag and caliculi, and lower calcareous stones more than 1.5 centimeter. And stones that are difficult to disintegrate by ASW like calcium oxalate monohydrate stones, bruchite stones, cystine stones, and urinary tract obstruction that needs simultaneous correction like PUC obstruction. And malformations with the reduced probability of fragment passage after ESW like Harshaw kidney and stones in the calcium divertla need PCNL. So just I will briefly go through the fluoroscopic guided puncture. What are the different techniques we'll use? We have three types, that is a bullseye technique, triangulation technique, and gradual descent technique. Bullseye technique. This is also known as eye of the needle technique. The target calyx is identified with the CM at 0 degree in the axial plane. Then the CM is rotated 30 degrees toward the surgeon. The calyx to be punctured would appear end on the fluoroscopy screen. A tilt of 5 to 10 degree in the caudal direction for the lower pole puncture and in the cranial direction for upper pole puncture is required to get an end-on appearance of the targeted posterior calyx. The position on the skin overlying the selected calyx is marked and puncture initiated. It is seen as a bullseye as a dot on the fluoroscopy screen. It is then advanced to puncture the calyx. Pre-efflux of urine confirms the position in the PCS. Now the second technique is a triangulation technique. This technique is of using two known points of reference to locate a third unknown point, that is the puncture of the PCS, guided by the biplanar fluoroscopy. The median lateral planes are assessed with the CM at 0 degree, and depth of the needle puncture is assessed by rotating the CM in the cranial or caudal direction by 30 degree. That usually in this, the targeted calyx is identified with the CM at 0 degree, and skin puncture is initiated in the 0 degree CM. When the CM is rotated 30 degree towards the head end for lower pole punctures, and is rotated towards foot end for upper pole punctures. The needle is adjusted in cephalocaudal position so that the orientation is towards the desired calyx. It is preferred to use 18 gauge needle rather than the 21 gauge needle with the triangulation technique, as its stiffness provides the better stability to help maintain the angle of entry. Now I will go through what are the most advantages for the fluoroscopic guided renal access. It's because of fluoroscopy you can clearly visualize the radiopaque caliculi. What we seen in the image, like contrast media can be used to aid in the stone localization, especially in radiolucent caliculi. And the fluoroscopic, we clearly demonstrate the anatomical details of the pelvical system. After uretic catheterization, we'll give the contrast, so that clearly gives the pelvical system anatomy. So it is easy for the puncture of the calyx. And you can clearly see the needle tip when you are doing the puncture in the under fluoroscopy. After the puncture, the insertion of the guide wire and guide wire manipulation is easy under fluoroscopy. And we know the CM is mostly available in all centers. We are more familiar with the CM when compared to ultrasound. So the fluoroscopy is more advantageous. And with high quality of current CM fluoroscopic equipment, there is a better quality image when compared to previous CM machines. The fluoroscopy is the better. Apart from the renal axis, we need guide wire insertion and manipulation, which is better visualized in the fluoroscopy. And tract dilatation and ampulla sheath placement, better we can see in the fluoroscopy. After completion of the procedure, it's easy for a residual stone evaluation in the fluoroscopy. You can easily see. When in the ultrasound, even the fat, small fat, you can also, the hyperechoic, you can see as a stone, but that problem is not there in the fluoroscopy. And post-procedure nephrostogram, you can easily do in the fluoroscopy. So another method now we are using combined the fluoroscopy with endoscopy, that is ECIRS. Because this flexible ureteroscopy assisted retrograde nephrostomy is a new option for renal access, especially in the non-dilated collecting system. When you have the non-dilated collecting system is there, if you use the combined endoscopy and fluor, it's easy for the renal access. The renal access is achieved under fluoroscopic guidance, but the tip of the needle is visualized by endoscopy and fluoroscopy combinedly. And we can continuously visualize all steps of the PCNL, from renal access to the ampulla sheath placement. There is less bleeding in this combined approach, and the procedure time is also shorter. And it's most commonly useful for the minimally dilated collecting systems and in obese patients also. When you're doing PCNL in obese patients, it's very easy if you use the combined endo and fluoro guided puncture. And in any case, failed percutaneous attempts of the failed prior terms of percutaneous axis. Then you can use the endo and fluoro combined. And especially in the stones in the calcium diverticuli, if you use fluoro and endo guided, then it's very easy for the puncture. And most commonly, the disadvantage of the fluoroscopy is the radiation. So how we'll minimize and overcome these radiation effects of the fluoroscopy? The fluoroscopic screening time during PCNL is the main factor of radiation exposure. The maximum allowed equivalent dose as per International Commission on Radiological Protection is not exceeding the 50 millisieverts, that is 50,000 microgray per year for occupational exposure. So this Halaval et al. Has done one study. In this, the mean screening time was 4.5 minutes in the PCNL. With the mean fluoroscopy utilizing 70 kV and 2 to 3 milliamps, a surgeon receives about 12 microgray to the lower leg and about 6 microgray to the foot and 2 microgray to the eyes and 3 microgray to the hands. So 1 millisieverts is equal to 1000 microgray. So we can, so up to 50,000 microgray is allowed for occupational exposure per year. Can one effectively reduce the radiation exposure to urology person in fluoroscopic examination? Yes, there are numerous methods to decrease the fluoroscopic exposure. The main principle is the radiation protection is ALARA, is as low as reasonable achievable. So optimization of the fluoroscopy by different methods, that is using modern equipment with technical innovations such as lost image hold to save and transfer the images that are to the adjacent screen, and pulsed fluoroscopy with the lowest possible frames that provide the better image, and minimize the exposed area by proper collimation of the X-ray beam, and place the image intensifier as close to the patient as possible. Use a laser guided C-arm. Now you can see in many hospitals, and use of visual and tactile cues rather than fluoroscopic cues. A designated well-trained technician, definitely accurate and precise position of the C-arm beam, definitely the fluoroscopy time will be decreased. So apart from this, the surgeon should wear properly utilized radiation shielding provided with the fluoroscopic equipment like lead apron, thyroid shields, lead impregnated glasses, lead gloves, sliding lead vinyl sheets which are available in the hospitals now. They all decrease the fluoroscopy time and fluoroscopy scattering in the operation theater. So in patients with large stones require multiple access, the procedure should be performed by experienced surgeons so that the exposure to the junior will be minimized. So these are the values of mean effective dosage of the fluoroscopy radiation to the patients. For abdominal X-ray is the 0.7 millisieverts. For the PCNL it is 4.5 millisieverts. Thank you.
Thank you. Dr. Chandramohan will present about ultrasound guidance.
Morning, all. At the outset, I would like to thank my moderator, Dr. Bhargav, SOGUS team for giving me this opportunity. I would be debating in support of ultrasound guidance in initial puncture of PCNL. So as we all know, the PCNL has, since it was invented in 1976, PCNL has become one of the most sought after surgery for large renal stones. And from then onwards, there are multiple advancements, improvements in the technique as well as in the equipment like mini-perc, ultra mini-perc and supine PCNL. So we all know, as a urologist, most important step for success in PCNL is safe and accurate puncture of the PCS, which almost 50% job is done. Traditionally, it was being done by a fluoroscopy guidance. But the fluoroscopy has got definitely problem of radiation exposure, especially for the urologist who will be doing these surgeries for so many years on a regular basis. There will be cumulative increase in the radiation exposure.
It is even problematic for patients of recurrent stones where they will be getting exposed to radiation for investigations like CT X-ray as well as for subsequent procedures like PCNL or IRS, etc. And it is more problematic in pediatric patients where the radiation exposure, even if it is very small, it can increase the risk of malignancy. So as previously said by Dr. Naveen, ALARA principle is advocated, but it still has got some radiation exposure. So the nowadays intra-op ultrasound is picking up as an important modality as an adjunct to fluoroscopy, either for initial axis, also for completing the procedure of the PCNL without use of fluoroscopy. So what are all the advantages put forward by ultrasound in using the doing the initial initial access into the PCN system? The most important, as previously said, is it can decrease the radiation exposure. And if you combine the ultrasound with color Doppler, you can clearly visualize the intrarenal vasculature, wherein you will be puncturing the calyx without injuring the vessels, thereby preventing the most important complications such as the bleeding. And another is, if at all you are doing upper polar puncture or lateral puncture, you will be seeing the pleura, lung as well as colon through the ultrasound, and then you will be preventing injury to the surrounding organs. And in patients of spinal deformities, there will be better localization of the kidney in those patients where the fluoroscopy will be giving some different picture. Another advantage is the ultrasound can be done either classically in supine prone position as well as supine position also, as well as in the lateral positions also. And in patients where there is concern about contrast toxicity, that is in CKD patients where the fluoroscopy utilizes contrast, the ultrasound access will decrease the contrast toxicity in those patients. And in some cases where you're not able to put the ureteric catheter into the PCS, where you will not be able to instill contrast and see the pelvic calcial system, in those cases also ultrasound can come in handy during the initial access. And as I said previously, in pediatric patients as well as in obese patients, radiation exposure is a problem. In those cases also, you can use ultrasound. So there are some disadvantages which will be I will be dealing later on, like additional cost, requirement of skill and training for the urologist, and technical demand in some cases of no hydronesis or mild hydronephrosis, or inability to clearly visualize the guide wire. Now, in the picture in this picture on the left shows a urologist performing a initial access by ultrasound, and the right side picture is showing the needle pathway into the targeted calyx, which is clearly seen. So again, you can by changing the direction of the ultrasound probe transverse and vertically, you can clearly visualize the pelvic calcial system and the apex of the calyx, and then puncture the calyx with the needle. So Doppler comes in handy, as I said previously, to delineate the vessels and then exactly puncture without any bleeding. And nowadays, many compact machines have come which we can easily carry into the theater rooms and then operate without occupying much space. So to put forward my advantages, I will be getting some scientific evidence from the reputed journals. So this is a randomized control study done by Abbas Basri et al., where they have randomized the patients 50 each into the ultrasound access, initial access by ultrasound by fluoro. You can definitely see there is a decrease in radiation exposure in the ultrasound group of 0.69 minutes compared to fluoro group of 0.95 minutes. And they have concluded that PCLN under ultrasound guidance is an acceptable alternative to fluoroscopy, and it reduces radiation exposure. This is our own study from Madhu S. Agarwal from India, Agra, and they have randomized the patients into fluoro axis as well as ultrasound axis of 112 patients each. And they have found out that all the parameters like mean time to puncture, mean number of attempts, mean time of tract formation, they're all less in ultrasound axis compared to fluoro axis, with no significant difference in successful access, stone-free rate, hospital stay, and complications in both the groups. This is a meta-analysis from World Journal of Urology, where they have studied 8 papers and then comprising of 966 patients, and comparing with the fluoro PCNL, ultrasound PCNL as comparable stone-free effects but a favorable safety profile resulting in a lower complication rate. Another meta-analysis review article from medical ultrasonography, where over a period of 15 years, they have studied 48 papers, and they have found out that it is comparable method with classical fluoroscopy access, but with a similar safety profile with a significant reduction in radiation exposure. The additional findings they have found it reduces the overall cost of the procedure by about 30%, and then it can be safely learnt and performed by urologists. Another study where I said ultrasound can be done in flank position, that is Hussain Karami et al. In Journal of Endourology, they have performed a study on 40 patients where they could get successful access in 100% of patients. So even lateral deepest position also can be done, ultrasound can be done. This is an interesting study from Journal of Endourology where they have evaluated the learning curve for the experienced surgeon. They have done a study on 100 consecutive PCNLs divided into 5 groups of 20 each, and they have found out that after 20 cases, the surgeon has become expert in doing the ultrasound guided access. So in order to learn this, at least 20 cases are enough. So what is the ultrasound guided access in children? So this study, they have done a retrospective comparative study from Iran, where they have taken 35 each of patients in ultrasound mini PCNL and fluoro mini PCNL. So what they have found out is the complications like blood transfusion and fever are less in ultrasound group. Therefore, they have concluded that mini PCNL and ultrasound is safe and as effective as fluoroglided PCNL. So another in obese patients, though this study shows that 93 patients underwent ultrasound guided and 42 patients fluoro guided. So they concluded that it may be difficult to do ultrasound guided puncture in obese, but definitely the radiation exposure to the obese people because surface area is high. So ultrasound guided puncture decreases radiation exposure. So what is the technique? Whether the technique decreases the if you improve the technique, whether it decreases the dependence on fluoroscopy ionizing radiation. This paper from World Journal of Urology, it says that the time of they have done a study on 30 consecutive patients divided into 2 groups of 15 each, and then what they have evaluated the puncture time and time of fluoroscopy in those 2 groups. They have found out that the time of fluoroscopy was considerably reduced in the as the experience in the number of cases reduces from 83 seconds to 22 seconds in the second group. So this is a review article showing the navigation systems for the percutaneous access to the kidney, where they have found out 5 different navigation systems for puncturing the renal pelvis before PCNL. For PCNL, they have concluded that the combination of ultrasound and fluoroscopy currently remains the gold standard. So what is the use of ultrasound? This study compares the B mode ultrasound in 54 patients compared to 57 patients who underwent Doppler guided ultrasound. What they found out is the hemoglobin decrease is less in Doppler guided ultrasound compared to B mode ultrasound. Therefore, B mode ultrasound is more safe and having less blood loss. So these are all the various studies which show that there is reduced radiation exposure, and some studies are showing that there is definitely the complications rate is less. So to conclude, I would say that in order to decrease the radiation exposure and in order to prevent some of the complications, it is better to go for a ultrasound access for initial access of PCNL, and then if it is, you can continue with fluoroguided access. Thank you.
I invite Dr. Naveen for rebuttal.
Yeah, just I will enumerate what are the disadvantages of the ultrasound compared to the fluoroscopy. The sonographic identification of needle tip in the pelvical system is very difficult, especially in the early stage of the practice. But in less experienced hands also, you can see the tip of the needle in the pelvical system under fluoroscopy. Especially in non-dilated systems and mild hydronephrosis, then ultrasound guided puncture is very difficult. Because of we have the retrograde ureteric catheter. If you put the contrast, it transiently dilate the pelvical system, so it is easy for the puncture under fluoroscopy. And especially again after puncture, again we need the fluoroscopy to insert the guide wire and to manipulate the guide wire for dilatation and for amplitude insertion. Especially in obese patients, very difficult to do the puncture and ultrasound guidance. You can easily see, even if you have the bowel gas shot also, the fluoroscopy, because of this retrograde ureteric catheter, the contrast you can easily see the pelvic system. The obese patients, the extensive bowel gas is a limitation for the ultrasound. You can see even any calcifications of the renal cyst or acute artery, arcuate artery calcification or any angiomyolipoma, even any fat content in and around the PCS is mimic as a stone. So the total stone clearance after when procedure also very difficult in the ultrasound. Because of this advanced ALARA as low as reasonable achievable, the radiation production, the fluoroscopy time is decreased. The last image hold with pulse fluoroscopy and using this Ledapron, and is more familiar to the urologist and is more available in all small nursing homes. Another disadvantage of the ultrasound is most of the operating theaters are not equipped with ultrasound machine in most of the centers, and getting the permission for PCP NDT and maintaining the files also a bit difficult. Most of the urologists not familiar with the ultrasound. But Dr. Chandramohan told visceral injury during fluoroscopy is substantiated by preoperative CT urography and proper planning of the calcium puncture before taking the case. You can easily avoid this visceral injury in even fluoroscopy guide also. And it can be done in all positions like supine, prone, in oblique position, even under fluoroscopy. Just I will quote one thing is when Dr. Peter Alken sir came to the Hyderabad, sir told when see the Suryabhabu sir done the PCNL in the Yashoda hospital, sir was done the PCNL in less than 1 minute, the PCNL puncture. So the fluoroscopy time is very less in experienced hands. So the radiation hazard will be very less. Already I told we can 50 millisieverts of radiation exposure can be allowed for occupational exposure, especially for doctors in a year. That is equivalent to 50,000 micrograys. So it is safe, do the PCNL puncture under fluoroscopy. Thank you.
I invite Dr. Chandramohan for his rebuttal.
I would like to propose the rebuttal by again quoting various papers which definitely show that there is definitely radiation exposure is decreased and the complication rate is increased in fluoroaccess like bleeding and the injury to the surrounding organs. So what are all the, you can overcome the disadvantages of ultrasound. One is cost wise, nowadays it has become almost an extension of physical examination. Thereby every urologist must be having an ultrasound and you can even register the ultrasound under PCP NDT now. And as I said, as I quoted in one paper, there is very quick to adapt and learn, minimum of 20 cases, which is almost gettable for every urologist in less than 1 or 2 months. And the cost factor also has come down with if you spend at least 5-10 lakhs at least, we can get an ultrasound in your operative suite, and then you can do the surgery. And the problem of no hydronephrosis or mild hydronephrosis can be overcome by instilling either saline from below or some diuretics IV, so that the pelvic calcial system can get dilated and then you can puncture. And regarding the visualization of the guide wire, nowadays the resolution of ultrasound is becoming so great that you can nicely see the guide wire while puncturing even into the pelvic calcial system and the ureter. So the new improvements of ultrasound, now they have contrast and enhanced ultrasound has come, which can increase the accuracy of puncture. 3D ultrasound nowadays it is picking up. And then another advantage, another development is sonic flashlight, where is the transducer, the tip of the needle will show the needle path of the ultrasound, needle path of the guide wire. So I will end my talk by showing this image where fluoroscopy image will be like this, and the ultrasound image will be the other one on right side. And I will leave it open to the floor to decide upon which type of initial access is required for PCNL. Thank you.
Our both panelists have presented their views with statistical background. Each percutaneous renal guidance technique has its own advantage and disadvantage, and there is no single technique is ideal in all circumstances. Our idea of getting puncture is entry through the fornix and to have shortest route and to prevent injury to the surrounding structures, maximum stone clearance with single puncture and less radiation exposure. So it's better to have ultrasound in our OT armamentarium. So the opinion of the house, please. Those who are in favor of fluoroscopic guidance, please raise your hands. Oh, okay, next, those who have favor for ultrasound guidance. Thank you very much. Almost. So the final conclusion is better to have ultrasound machine in our OT armamentarium. Thank you very much, Dr. Naveen Kumar and Dr. Chandramohan.
Thank you.
Now we are move on to next topic. This topic is for urology residents. The topic is 20 mm renal pelvic calculus, whether to go for mini perk or RIRS. I invite Dr. Bhaskar Reddy, urology resident from Kurnool Medical College, Kurnool. Dr. Sanket, urology resident from Yashoda Hospital, Malakpet. There are various minimally invasive modalities like ASWL, PCNL, and RIS for the treatment of renal stones. Selection of the treatment depends on various stone-related factors like size, shape, and site, patient-related factors like obesity and other comorbid factors, and renal anatomical factors like single kidney and malformations in the kidney. Standard and mini PCNL methods are currently the best treatment modalities for more than 2 centimeter stones. But the procedure may cause blood loss, neighboring surrounding organ injury, and the parenchymal injury to the kidney. So the RIS has gained momentum since last decade. Currently, we see urologists perform RIRS independent of the stone size. Can be easily accessed to the most difficult calyx because of the increased flexion mechanism of newly formed new scopes. Guidelines recommend flexible URS as an alternative treatment of choice for upper urinary stones less than 2 centimeter stones. This is a paper published in Journal of Urology in 2013. The preferred treatment for less than 1 centimeter stone is ESWL, more than 2 centimeter stone is PCNL. Now, on decade has lost. Now, most of the surgeons are doing RIRS and many improvements in PCNL technique also like mini perk. Now, we hear from our panel doctors. Now, I invite Dr. Bhaskar Reddy present his views about mini perk. Thank you.
My debating topic is mini perk. The incidence of stone disease is high, so we are busy in breaking the stones. We have PCNL, ESWL, RIRS, and each technique has advantages, disadvantages, and I am not against any technique. What is the best option for 2 centimeter renal pelvic stone? We have heard a lot about mini PCNL and it is getting better nowadays. As per present guidelines itself, PCNL is the first line of treatment for renal stones more than or equal to 2 centimeter. The mini PCNL with the use of smaller sheets and nephroscopes will be a good option to manage kidney stone, high stone free rate, and low complications. We have evidence that standard PCNL is associated with higher complications and its use is getting limited even though the stone clearance is good. What is mini PCNL and why do we have to do it? It is a miniaturized PCNL where smaller percutaneous tract, that is 14 French to 20 French sheath, is used with smaller nephroscopes. Mini PCNL has higher stone free rates and low complications. And you might ask the question, why not treat every renal stone with PCNL? Yes, a day may come when all sizes of renal stones can be managed with PCNL. Smaller the scope, lesser or no morbidity. And what are the goals of ideal technique? Complete stone clearance, less operative time, hemorrhage, radiation, infection, short hospital stay, cost effective, and we can achieve all of these things with mini PCNL. As I said, mini PCNL has comparable stone free rate, less parenchymal injury, less hemorrhage, analgesia, and short hospital stay compared to standard PCNL. And mini PCNL can also be done tubeless or totally tubeless, and RIRS we have to stunt. Mini PCNL is not just a scope becoming smaller. It also includes advancement in stone retrieval like suctioning and whirlpool effect. It is a single stage procedure. And RIRS has longer operative time. RIRS group patients suffer more post-op complications, of which urosepsis was most common and deadly. And RIRS has stone-free rate less than mini PCNL, and it may need auxiliary procedures after that. We have no other option than mini PCNL in case of matrix stone. Better option for fragmented or forgotten digestion with calculus in renal pelvis. And there are many special anatomical situations that favors PCNL like infundibular stenosis, calyceal diverticulum, horseshoe kidney, pelvic kidney, and ectopic kidney because of high insertion of ureter, and UJO, ureteral stricture, BPH, urethral stricture, where RIRS will be very difficult in these cases. And PCNL is considered first-line therapy for renal stones greater than 20 mm in children with stone clearance of approximately 90%. And PCNL has replaced open surgery as a treatment of choice for large stone burdens in all children. Unlike RIRS, the success of PCNL is relatively independent of stone location and stone composition. PCNL accomplishes higher stone free rates and requires fewer auxiliary procedures than RIRS for renal stones between 1 to 2 centimeter. And there are many studies saying mini PCNL is a better treatment modality for higher single step stone free rate, shorter operative time, and fewer post-op complications. And RIRS has stone free rate slightly less than mini PCNL. And there is another study, mini PCNL is advantageous because of high stone free rate in the post-operative first one and low need for, need for secondary interventions. And the other study says mini PCNL for the treatment of renal stone size less than or equal to 2.5 centimeter has high stone free rate, shorter operative time, less requirement of digestant, and near similar post-operative pain and complications compared to RIRS. Coming to RIRS, why not RIRS? There are drawbacks. RIRS is a double stage procedure most of the times. We need to stun the patient prior to surgery for best results. And not all the orifices are friendly all the time. Beginning from the meatus to PUJ, everything should be normal for a RIRS procedure. And RIRS scope is very difficult to maintain because of cost, easy damage. It is more troublesome with large prostates and fish hook ureter. And RIRS scopes are costly and less durable. And even cleaning and sterilization can also cause a damage to the scope. And laser is a must for RIRS. It is very costly instrument again. A 2 centimeter stone volume is high and needs longer operative times to clear the stone completely. And as the operative time increases, the complications of RIRS also increases.
A 1 centimeter renal stone needs 125 particles of each 2 mm size to clear the stone completely, and 1000 particles of each 2 mm size for a 2 centimeter renal stone. So if the stone size becomes double, the duration won't become double, it is more than that. This is the reason why stone clearance rates in RIRS decreases as the stone size increases. And there are many complications: failure to access, failure to fragment, there can be mucosal trauma, ureteral perforation, devastating complications like ureteral avulsion due to use of excessive force. And sepsis is a devastating complication with RIRS. Calyceal perforation can happen, pyelonephritis, urinoma due to high intrarenal pelvic pressures. Ureteral stricture is one of the delayed complication. More recently, the incidence of postoperative stricture is reported to be 3% to 6%. There are studies saying large stone size, positive urine culture, and long operative time were significantly associated with risk of SIRS after RIRS for kidney stones. And coming to intrarenal pelvic pressures during flexible ureteroscopy. And because of high intrarenal pelvic pressures, there will be pylovenous and pylolymphatic backflow, placing the patient at the risk of septicemia. And we have studies saying that in RIRS, the pressures are going beyond 328 mm of Hg. And the threshold to cause sepsis is only 50 mm of Hg. And coming to the learning curve, and at least study says that at least 60 cases are needed to reach the plateau of RIRS. My opinion, in short, a proper puncture and use of pneumatic lithotripter, a 2 centimeter renal stone can be removed easily in short time in a single stage with good stone clearance, with less parenchymal injury, less bleeding, less urine extravasation, less post-op pain and analgesia. Thank you.
Invite Dr. Sanket to present about RIRS.
Good morning, sir. Thank you for giving me this opportunity for speaking. I will be speaking in favor of RIRS in 2 centimeter pelvic stones. Main aim in treatment of renal stone is clearance of stone, complete with least morbidity. Advancement in technology during recent years has made RIRS efficient and safe option for management of renal stones. Recent development in flexible miniaturized ureterorenoscopes and auxiliary equipment have made this procedure easier and more effective with increased success rate. Why RIRS? RIRS procedure is easy to perform. Patient positioning is comfortable. The duration of procedure is a short duration procedure. There is easy accessibility to whole correcting system. Simultaneously, ureteric stone could be dealt with the pelvic stone. The post-operative hospital stay is less of patient. Patient return to activity is early and the procedure is cosmetic. The advantages of the procedure are it is a non-invasive procedure. It could be done in SVL resistant stone and non-opaque stones. Both renal and ureteric stone can be dealt in a single sitting. Bilateral, if we are dealing with bilateral renal stone in single session, we can clear it out with RIRS, and there is less minimal bleeding, means less hematuria. Again, there is a significant decrease in post-operative complication because of RIRS. Better intraoperative visualization because of the advancement in flexible scopes. Improved stone clearance as there is improvement in fiber breaking mechanism. There is a less learning curve for the surgeon who are operating, and it can be operated with less skilled supporting staff, and there is less radiation exposure. These are some special scenarios in which RIRS is the only indication. in pregnant females, bleeding, if a patient is having a bleeding diastasis, pelvic stones in children, obesity, renoureteral malformations, patient having solitary kidney, skeletal muscular deformity. For IRS instrumentation, you required as flexible scope, energy unit, flexible accessories such as guide wire access sheath, video camera unit, and fluoroscopic unit. Procedure wise, once you get a ureteric access sheath in place, you pass a flexible ureteroscope, and once a flexible ureteroscope is in position, the stone is fragmented, and after fragmenting the stone could be removed by a basket. These are the articles supporting why RRS is better procedure. I will quote some of the articles. Why not mini perk? The complications of these procedures are dreadful. One of the serious complication is acute hemorrhage. Hemorrhage could be due to multiple access entry, increased tract size, prolonged operative time, pelvic perforation, technical errors, and wrong calyceal entry. There could be delayed hemorrhage in post mini PUC patients because of pseudoaneurysms and AV fistula. Patient might have visceral injuries, pleural injuries, collecting system injuries, post-operative fever, sepsis. In some cases, in very rare cases, venous thromboembolism is also seen. There is collecting system obstruction, sometimes loss of renal function, and very rarely death. There are position-related complications also in prone PCNL. There could be ocular injury, facial nerve injury, cerebrovascular incidents, malposition of extremities leading to peripheral nerve injuries. Patient-related complications, patient have a delayed recovery, more post-operative pain, more radiation exposure. As most of these patients have a recurrent stone formation history, so they might have a future radiation exposure also. These are all the disadvantages. Means patient have a long hospital stay, invasive, it is an invasive procedure, long learning curve for surgeon. The staff should be skilled enough, and there is increased radiation exposure. So in short, if I summarize, RIR is position wise, it is a more comfortable procedure. Learning curve is less, hospital stay is less, patient recovery is early, the accessibility to the track is easy, radiation exposure is minimal, and stone clearance is as good as mini buck. So I can conclude that RIR is a safe and effective method for 2 centimeter stone. RRS compared to PCNL offer the best outcome in terms of radiation exposure, and RRS have similar efficacy as of PCNL, but with less post-operative complications. Thank you.
I invite Bhaskar Reddy for rebuttal.
Just to remember that we have also flexible nephroscopy option to view all the entire intrarenal collecting system. Coming to radiation exposure, there are studies showing that various operating room personnel are within safe radiation dose limits during PCNL. It is less than 50 millisieverts per year. And mini PCNL, coming to risk of bleeding, there is not much risk, and the study says that mini PCNL is usually related to less blood loss and shorter hospital stay than standard. And mini PCNL is associated with less post-operative bleeding and pain than standard PCNL. And coming to renal parenchymal injury, there are studies says that the percentage of scar volume was negligible in all cases. And DMSA scintigraphy showed no scar tissue in any case. For a 2 centimeter renal pelvic stone, I don't want to do RRS to put my patient at the risk of death. If not, ureteral avulsion can happen, perforation or delayed ureteral stricture, even the chances are less. We all know it is devastating. The patient develop urethral stricture. I will do mini PCNL at the cost of negligible parenchymal loss or bleeding or radiation. And there are some studies says that supine puncture is better for RARS to decrease pelvic pressures and sepsis. For that purpose, in mini PCNL, we naturally have ureter to take care of that. Thank you.
I invite Dr. Sanket for rebuttal.
Complication of RRS such as sepsis can be managed by proper antibiotic coverage, patient selection, and restricting the duration of procedure. Cost of RRS and nephroscope are more or less similar only. With advancement of technology, we might see more miniaturized flexible scope with temperature and pressure sensors, thus bringing down the sepsis rate in RRS. These are some articles I will like to quote. In this article, they have clearly mentioned the amount of the amount of sepsis in RIRS cases is less. It is, however, given that there is a serious life-threatening complication, knowing to its potential risk factor is extremely important. This is another article I have to I will quote, in which they have explained that flexible ureteroscopy, technological advancement and current indication have a better outcome in the treatment of urolithiasis. So I will conclude. Thank you.
Thank you. Dr. Bhaskar and Dr. Sanket both have presented very well about with the statistical analysis. The final conclusion is patient should be informed about various modalities like their chance of stone clearance and morbidity of the procedure. During last decade, many urals are doing RIRS irrespective of the stone size. Treatment should be individualized according to the site of the stone and patient characteristics, cost effectiveness, and availability of the expertise. And with the advent of RIS, we are losing the feeling of PCNL puncture. And if you look around the OT while doing puncture, everybody under tense, from the anesthetist to your assistant surgeon, OT boys. After seeing the urine from your PCNL puncture, and everybody will relax. With the advent of RIRS, we are losing that feeling. Thank you very much for this session. Thank you, SOGUS, for giving me this opportunity.
I request Dr. O. Ramesh sir to come over the dais and present the mementos. Dr. Bhargavardhan Reddy. Dr. G. Chandramohan, Dr. P. Naveen Kumar, Dr. Bhaskar Reddy, and Dr. Sanket. I just want to make an announcement about the CH Visweshwar Rao quiz will be there after the oration. So the next session is Professor Dr. S. Jairam Reddy oration, and the orator is Dr. S.V.S. Rao. I request Dr. S.V.S. Rao, sir, to come onto the dais. And I also request President SOGUS, Dr. T. Purushottam Rao, to come onto the dais. Dr. Yakaya, sir, organizing chairman, to come onto the dais. And I also request Dr. G. Ajay Kumar, counsel, to come onto the dais.
Yeah, good morning to all. I would like to give a brief introduction about the orator today. Dr. S.V.S. Rao sir is a senior most urologist practicing now at Kakinada. He has done his MCH urology from AIMS, Delhi, and he has fellowship in minimal access surgery, fellowship in Indian Medical Association of Gastrointestinal Endosurgery, worked in NIMS, and he has an World Health Organization research associate in male infertility, and he has got various memberships, publications, awards, and achievements to his honor. And he is a visiting member of GSC team to Missouri, USA, and he is a charter member of Rotary Club of Kakinada, and he does extensive work in the field of the Rotary. He is much interested into the Rotary the organizations, and he is the president of Rotary Club of Kakinada during the period of 1996 and 97, a long 1 year duration, and is the chairman of Rotary Club Old Age Home. And he was awarded the best paper and best poster in the AP Society of Genitourinary Surgeons, and is a member of AUA, American Urological Association, and is a member of International Society of Urology, and he is a state president of AP Nursing Homes Association, president of Apna district branch, and president of Indian Medical Association IMA Kakinada. And he has attended many conventions in US, UK, Canada, Hong Kong, Dubai, Singapore, Turkey, and Thailand. And he has got a lot of interest in the profession of teaching and reading, and he has got a lot of to the service to the humanity. With this, I would request sir to come and give the oration.
I thank President AP SOGUS, Dr. Purushottam Rao Garu, Secretary Dr. Gupta Srinivas for giving me this opportunity to deliver prestigious Dr. Jairam Reddy oration. Thank you, Dr. Ajay, for your introduction. I am going to dwell upon my 32-year journey in urology in Kakinada. Professor Dr. Jairam Reddy is from Mahbubnagar district. He did his MBBS from Usmania Medical College, Hyderabad, and he did his MS General Surgery from the same college in 1984. He did his MCH Urology in 1988. Since then, he worked as an assistant professor in the Department of Urology of Usmania Medical College till 2000. After that, he was a professor of urology and head of the department in that same hospital, Usmania, till his retirement in 2012. He established the first urology group practice in state at a Hyderabad Kidney and Laparoscopic Center. The same hospital continues to be the training center for young urologists. He started renal transplantation in quite a few private hospitals. He was a postgraduate teacher and examiner for more than 2 decades. His dedicated professional work includes performing many renal transplantations, complex and radical urological procedures, including reconstructive surgeries, with enormous success rate. He has been selected by the Union Government of India to impart training as a trainer of trainees in National Family Planning Department for microscopic vas and tubal recanalization as well as no scalpel vasectomy. He conducted many state and national level conferences. We still cherish those memories of 2016 ISKCON, which was successfully conducted by him as the organizing secretary. He conducted many workshops and academic programs. He presented many papers and chaired many sessions. He has been a part of urology associations and other teaching faculty associations. He's always very charming, modest, and ever smiling. To begin with, I've been doing urology practice at Kakinada for the last 32 years. I did my schooling and college in Tadikonda Residential School and Nagarjuna Sagar Residential College. After that, I proceeded to All India Institute of Medical Sciences, where I finished my MBBS in 1982. I did my MS surgery in 1986 and completed MCH urology in 1989 at AIMS Delhi. In between, I worked as WHO Research Associate in male infertility at AIMS in 1987. I worked as a urologist at NIMS during the 1989 and 90. After that, I went back to Kakinada. I started a small clinic with 3 rooms and a hall, 1 room for consultation, 1 room for operation theater, and 1 for the inpatient. My initial equipment was TUR prostate equipment, uterorhinoscopy, monopolar cautery, and ultrasonic lithotripsy. That photo, you can recollect, Professor Man Singh, Narendra Man Singh, head of the Department of All India Institute of Medical Sciences, he came to Kakinada to inaugurate my small clinic. He was the person who started urology department in AIMS, and he was the first urologist in the North India to start a urology department. At that time, ureteroscopes were quite big in size, 9.6 to 11 French. We used to struggle for ureteroscopy also. Ultrasonic lithotripsy used to be there, and it used to take quite a lot of time to break the stones. Then we switched to lithoclast, which was first in coastal Andhra. In 1992, I purchased a small nursing home with 14 beds, and then I expanded to the 50-bedded Arogyasri Hospital in 2007. In 1994, I went to USA on a Rotary Scholarship and visited various urological centers of excellence, including Massachusetts General Hospital at Boston. After coming back from USA, I purchased the PCNL equipment and SIAM and started PCNL at Kakinada. Nephroscopes were 26 in size, used to struggle initially, and my mentors used to be Dr. Subramaniam from Apollo and B. Suryaprakash. They were with me at Nijams. In 2000, I again went back to AIMS to learn laparoscopy, and I did fellowship in minimal access surgery and fellowship in Indian Association of Gastrointestinal Endosurgeons. I was performing lap cholecystectomy, varicocele ligation, and lap archodopexy. I didn't put much effort into lap suturing, so I didn't progress much in lap urology. In 2014 and 15, I got training in RIRS at Mumbai by Dr. Kanda Paik, and I went to Preeti Hospital, Dr. Chandramohan for training. I purchased flexible ureteroscope and homium laser, 30 watts for RIRS. Minipuck equipment was also purchased simultaneously, and I was preferring Minipuck over RIS due to Arogyasri load. I had my triumphs, jubilations, and nightmares during this period. We completed more than 25,000 urological procedures, including more than 5,000 PCNLs, during this time. With many trials and tribulations, we started renal transplantation in 3 centers in Kakinada, one at Apollo, one at Medical Specialties, and another at Trust Hospital. Only one center is running now, transplantation program. I'm proud to say that we were the first individual center to start PCNL, Swiss lithoclast, ESWL, radical cystoprostatectomy, laparoscopic urology, RIRS with laser in Godavari district. I published many papers and presentations at national and international levels. We remember more of black pearls and nightmares than the successes in practice. These black pearls and nightmares haunt throughout our career. When I purchased the TSW machine, it was 20 lakhs from Israel Medispec company, and it was a disaster. Because the success rate was only 60%, lot of residual fragments used to be left over, and we lost a lot of money on ESWL. Coming to the renal segment, one patient in 1990, I done a nephrectomy for pyonephrosis. He was a child of 14 years. His father gave the consent for the nephrectomy. But he requested me not to reveal this to his son. Last 2 years back, he came to me as a young man and he started blaming me that I removed his kidney without his consent and I sold it off for monetary gains. He went to the Superintendent of Police and he went to the AP Medical Council, he went to the court. Superintendent of Police immediately ordered inquiry and case registration. AP Medical Council sent a DMHO to the Kakinada to inquire about it. So after extensive investigations, then they rejected the allegations, but the case is still pending in the court. Another nephrectomy I still remember, which was done for a poorly differentiated anaplastic carcinoma. From the drain side, there was a lot of bile ooze. That was due to injury to the tail of the pancreas. Luckily, it subsided after 2 weeks, but same patient developed tumor metastasis at the incision site. And patient died after 9 months. So it was a very bad prognostic case. And another RCC, still remember, radical nephrectomy was done successfully, but 3 years later, a patient came from Narsapur, West Godavari with a HIV. We transfused 2 units of blood during surgery. At that time, there was no authorized official blood bank in Kakinada. So most probably the AIDS came because of our transfusion. Then I felt bad and we started a first blood bank in Kakinada apart from GGH through Rotary when I was the president as a Rotary Club. Another RCC patient with a huge tumor burden developed sepsis secondary to tumor dissemination. Similarly, another big RCC with a huge thrombus in the IVC, when I was giving the skin incision, it went into as a heart as a pulmonary embolism and we couldn't resuscitate the patient. So then we realized any clots in IVC, we should have a cardiothoracic department's help. Coming to the ureter section, during this period, for 2 months, we had a lot of urosepsis. Our patients were developing urosepsis and we lost 2 patients because of severe sepsis after ureteroscopy. We did everything to prevent sepsis by giving higher antibiotics, frequently changing the sterilization fluids, getting urine cultures, changing the sterilization methods, but nothing worked for 2 months. Then Rauf sir suggested me that we should flush the ureteroscopes with antibiotic solution or Sidex after each case. The sterilization of inside of the ureteroscope is more important than the outside sterilization. Then we started doing it and we never had sepsis since then. We had 2 cases of ureteric avulsion, one at the upper ureter and second one at the lower ureter. Upper avulsion is due to telescopic invagination, which was not recognized during the procedure. The second lower ureter avulsion is due to forced entry into the lower ureter of the ureteroscope because of overconfidence. The upper avulsion was managed by the auto transplantation of the kidney because he had a sufficient stump of the upper ureter. The second one was managed by the ureteric reimplantation. Coming to the bladder, initially we used to do radical cystectomies, but most of the patients after 2 years they came with systemic metastasis. At that time, neoadjuvant chemotherapy was not there. Now, after neoadjuvant chemotherapy and multimodal therapies, the metastasis patients have come down. One patient presented with a hematuria, cystoscopy was done, the biopsy was taken from a hemorrhagic area. But that patient was an advocate. Later on, he developed a CA bladder and he went to the court and sued it. That I didn't diagnose a CA bladder, but it was dismissed because we were able to show that the biopsy was taken. For retained Foley's, there are many methods, but they always don't work. Initially, sometimes when other methods don't work, I used the optical ureterotomy sheath over the catheter and punctured the balloon with a needle. For this, I received the best poster award in the SOGUS only. Retained digestion is very common in Kakinada. They come after 3 years. We have to do CLTs, URSL, PCNL for the same patient. In the prostate section, we see a lot of patients, when we do a TURP for 30 grams and all, they come after 3-4 years with 100 grams prostates. It is due to something in the pathology to do with, not with the procedure. Usually patients blame that we left some tissue and all, but very small prostates when do it, they come with a larger prostates also. So benign, BPH is a benign tumor type. They can develop from a single cell also after some. One senior ENT surgeon, he never allowed a digital rectal examination. He always used to take medicine, and that was a pre-PSA era. He ultimately succumbed to the metastatic CA prostate. So we should remember that Lavand Baylis, you can't put a finger in, you should put a foot in. But the doctor insisted that he never allowed me to do a rectal exam, fortunately. Coming to the urethra, in spite of so much of literature, so much of conferences, they say that BMG is the best, but long-term results of BMG also is not so good. After 3, 4, 5 years, success rate is only 50%. Similarly, optical ureterotomy should not be done away with, still has a role in the management of strictures in suitable patients. For hypospadias, I usually do, for long hypospadia, modified Dennis Brown technique. There's two-stage repair where you leave a island mucosa, urethral mucosa, and you put the skin over the buried island flap. It gives a very good results. Unfortunately, most surgeons and textbooks have abandoned it, but it's still very good procedure, modified Dennis Brown technique. You can use it for the long strictures also, chronic strictures also. Same procedure when you do it in the 2 stages. You can prevent majority of the fistula in hypospadias by keeping the meatus wide open. Instead of trying too hard for the cosmosis at the meatus, if you keep the meatus open, the fistula rate comes down drastically. PVT and thromboembolism. In endoscopic surgeries, we neglect this aspect. We tend to think that the embolism is very rare. But I have seen a patient after TRP, 4th day he went to a bathroom and collapsed with pulmonary embolism. Another PCNL patient, he went home and again after 7 days came with a deep vein thrombosis and developed a pulmonary embolism, succumbed. So we should, though it's rare, but DVT can occur and we should be very careful in those patients who are prone to deep vein thrombosis and pulmonary embolism, even after TRP, PCNL and minor surgeries. Varicocele, though success rate is low, the patients who have children are very happy. So you should not abandon varicocele surgery for the infertility. Similarly, effect of interferon on idiopathic oligospermia. I presented in the SIU Montreal and was received very well. One patient who troubled me is the varicocele grade 3 who operated for pain. That patient, post-procedure, he went to a sonologist, got an ultrasound. They told him that there is a mild varicocele. Then that patient went to a senior surgeon at Amalapuram. He told him that there was no scar in the testis, so varicocele was not done. Actually, we performed a high ligation of the varicocele, but the doctor told him that there is no scar, scrotum, so there is no surgery. So that patient came back to Kakinada and made my life miserable with a lot of complaints, dharnas, court litigations, and went to collector. So better we never operate on the varicocele for pain. I prefer inguinal ligation with a loop. Subinguinal incision is always messy with the damage to spermatic artery is quite high, and there are so many enormous veins to be ligated. In the pediatric urology, the infants who come with posterior valves and renal failure, initially if you do a vesicostomy, they do very well. In posterior valves, antegrade fulguration is better than a retrograde fulguration because we tend to over-fulgurate or underdo it in the retrograde approach. So causing strictures or leaving residual valves. Whereas in antegrade fulgation of the posterior valves, we can do precisely fulgation of the valves or incision of the valves. I presented this study in the AP SOGUS and I got the best paper award for this. We lost a 3-month-old child post-operatively after pyeloplasty and 4th day, who is doing very well. It is sudden infant death syndrome, maybe due to aspiration. So infants, we have to keep it in mind that they can have death, like sudden infant death. Abdominal undescendances are extremely difficult to bring down, and also, even if you do in 2 stages, they tend to atrophy over a long period. Pyeloplasty post-operative, they say that DTP is a better, but I always find IVP is more interesting. I mean, it can delineate the PUC better than the DTPA. Whereas ultrasound is a bad for follow-up. Sometimes we can use ureteroscopy to evaluate the UPJ, a follow-up of pyeloplasty. In infertility, vasoabdominal anastomosis and vasovascular anastomosis are very satisfactory. Whereas if filariasis is there, we should avoid it. After the availability of IVF, number of these surgeries have come down. In female stress incontinence, I performed births, MMKs, TAMIs, needle technique, Raj technique, TVT and TOT procedures. There is no difference in the success rate, and significant number of patients still they develop recurrence over 5-year period. So counseling is very important in female stress incontinence. PVFs, my preferred technique is O'Connor's transabdominal repair. Initially, yes, we used to have more of abstract fistula. Now we are getting the post-hysterectomy, secondary to laparoscopic hysterectomy. One patient, when my abdomen was opened, everything was frozen and intestines were adherent to the abdominal wall. And there was injury to the intestines and repaired and wound closed. So that patient, vaginal repair was done at a later date. PCNL complications decreased after the scopes have become small. Embolization for bleeding was done in 2 patients, bleeding because of pseudoaneurysms. Both patients had a straightforward, simple PCNL procedures with straightforward punctures. 2 patients developed hemothorax. Both of them are in supracostal punctures. One colonic fistula was seen in a small kidney with a stone. Nephrostomy was pulled into colon and the fistula healed on a conservative treatment. One heminephrectomy was done for bleeding when embolization was not available in Kakinada. So to conclude, for the junior urologists, don't fall prey to the technology advancements driven by the manufacturers. You tend to lose a lot of money. If the money we spend on the equipment is invested in equity and real estate, we will make more money. Let the corporates purchase equipment and you focus on the skill development. Developing world-class service is possible in Tier 3 towns also, if there is a will and passion. Life is a journey with problems to solve and lessons to be learned, but most of all, it is experiences to enjoy. Thank you for your patient hearing, and thank Vinith for giving me the opportunity presenting this.
Thank you, Dr. S.V.S. Rao garu. We know how experienced you are and your vast wisdom. You shared it all with us. And a lot of juniors, I think they will learn from your experiences. Your service sector is also, we are appreciating very much Rotary. Thank you, sir.
So now I request our President Purushottam Rao Garu to honor Dr. SVS Rao sir with gold medal. I also request Dr. Yakaya sir to present a memento to Dr. SVS Rao. So the next program is Dr. C.H. Visveshwar Rao quiz, and I request Dr. Ravichandra Puvada to come over the dais and conduct the program. So I request Ramakrishna to distribute papers. And good morning. I request all postgraduates to take the papers and just fill out your names and your mobile number. I welcome you all to the Dr. C.H. Visveswara quiz for postgraduates. Just raise your hand if anyone has not received your answer sheet. Better all postgrad PGs to just occupy the front rows. It will be easy for you are comfortable there only. You are just fill out your details. Once you are ready, we'll start the quiz. All our senior members are expecting you in the front rows. Please occupy the front chairs. Okay, once you are seated, we'll start the quiz. There are 20 questions and we shall take 1 minute for each question. Just write, most of them are MCQs. You put your response as A, B, C or D. And
Session of the Quizmaster is final. Sir? Have some space between you. Okay, we'll start the quiz. The first question is, peace trial is related to triple therapy for metastatic castration-sensitive prostate cancer, comparison of multiparametric ultrasound versus multiparametric MRI for diagnosis of CA prostate, FDG, PET or CT-based chemo, dosage adjustments in seminoma, a role of PARP inhibitors as first line in MC RPC. About peace trial. Next question. A 24-year-old, there is a sudden onset of testicular pain following a recent upper respiratory tract infection. That's an ultrasound image. Second picture is the Doppler. Third is the surgical specimen. Just mention your diagnosis. Epididymoarthritis, seminoma testis, testicular infarction or torsion. Go to the next question. What is select MDX? What is select MDX? An urine test for CA prostate, urinary spot test for carcinoma bladder. It's a prostate biopsy technique. It is MDR TB bacilli. What is select MDX? Next question. Name this British physiologist, a musicologist and composer known for his unusual scientific presentation of a chemically induced erection by pulling down his own pants. Who demonstrated erection with epaverin. This is fill in the blank, no MCQs. Next question. The following is suggestive of severe antenatal hydronephrosis. APD of more than 10 mm in second trimester, more than 15 mm in third trimester, and Society of Fetal Urology showing parenchymal thinning. Option B is APD more than 20 mm in second trimester and 30 mm in third trimester, 15 and 30, 10 and 20 in second and third trimesters respectively. Next question. Hereditary syndromes associated with pheochromocytoma. These are all the syndromes associated with pheo except MEN2A, 2B, VHL, and MEN1. Next question. Red colored urine is associated with using these medications. Amitriptyline, metronidazole, methyl dopa, lead poisoning. Next question. Medications associated with retention of urine as their side effect. Levodopa, phenylephrine, using loratadine or digoxin. Next question. Sensitive detection and characterization of a renal mass is possible in which phase of CT angiogram? First phase or corticomedullary phase, nephrogenic phase or excretory phase? First phase is the vascular phase. Next question. First therapeutic cancer vaccine approved by FDA. The OncoBCG, hepatitis B vaccine, triple U cell T, or HPV vaccine. Next question. Embryologically, bladder, urethra, and prostate, they develop from genital tubercle, mesonephric duct, paramesonephric duct, or urogenital sinus. Next question. The most important risk factor for a couple's fertility. Maternal age, age of the female partner at menarche, or sperm morphology. Next question. OncoBCG is uniformly resistant to which anti-tubercular drug? Rifampicin, streptomycin, ethambutol, pyrazinamide. Next question. Correct French numbers for color codes matching our national flag. Police catheters. You read out the numbers for yourself. Okay, next question. What is this device? Hamilton Irvine box. It's an incontinence belt, the conduit appliance, A suprapubic drainage device or a stone catch device? Next question. Classification system for urethral injury. Clavian system, Colapinto classification, UTD classification, Vancouver classification. Based on RGU. Question. Anderson Hines pyeloplasty. Professionally, who are they? Pediatric surgeon and plastic surgeon, or urologist and pediatric surgeon, pediatric surgeon and general surgeon, or a neurologist and a plastic surgeon? Anderson and Hines. Who were they? Next question. Which of the following is true regarding HOAG laser and TFL, thulium fiber laser? Holmium YAG pulse energy is as low as 0.025 joules. TFL is water cooled and has mirrors in its design. Holmium fiber is as small as 50 microns. The proximal fiber end damage is very less with TFL. Which of the following is true? We'll go to the next question. India's first oral alternative to ESA, erythropoiesis stimulating agent for management of anemia in CKD patients. Alternative for erythropoietin injections. Dabigatran, dasatinib, desidustat, daptomycin. Which was recently launched by Zydus in India. Oral alternative for erythropoietin injections. Go to the last question. The only intralesional injection approved by FDA for Peyronie's disease. Verapamil, triamcinolone, collagenase Clostridium histolyticum, interferon alpha 2b. Okay. Please hand over papers to Ramakrishna. You have taken all the papers? You have taken, we'll go for the answers. We'll go for the answers. This trial is a triple, it is related to triple therapy for MCSPC, that is androgen deprivation, docetaxel and abiraterone. Second question, it is a focal testicular infarction, a sudden onset of testicular pain following upper respiratory tract infection which precipitates procoagulative things like sickle cell anemia. Select MDX is urinary test for CA prostate. It tests the biomarkers like HOXC6 and DLX1. It's something like a spot test. Is Dr. Gilles Brindley, who demonstrated papaverine-induced erection on his own. APD of more than 10 mm in second trimester and more than 15 mm in third trimester is indicative of severe antenatal hydronephrosis. Hereditary syndromes associated with FIO, all are associated except MEN1. Multiple endocrine neoplasia type 1, they is not associated with FIO. Red colored urine is associated with chronic lead poisoning. The Other colors associated with these medications are shown. Digoxin is not associated with retention of urine. The levodopa, phenylephrine, and loratadine, drugs commonly used, this phenylephrine, loratadine for cold, are associated with retention of urine. Sensitive detection and characterization of renal mass is possible in the third phase, nephrogenic phase, that is 90 to 180 seconds after injection of contrast of CT angiogram. Sipuleucel T is the first therapeutic cancer vaccine approved by FDA for CA prostate. Bladder, urethra, and prostate, they develop from urogenital sinus. Maternal age is the most important risk factor for a couple's fertility. OncoBCG is uniformly resistant to pyrazinamide. Orange, white, and green, the Foley catheter codes 16, 12, and 14. This is a suprapubic drainage device used in earlier days, Hamilton Irvine box. Collected from British Association of Urology Museum archives. McCollum-Colapinto classification is the classification system for pelvic fracture urethral injury based on RGU. Anderson is a neurologist and Hines are plastic surgeon. Proximal fiber end damage is very less with TFL. That is the correct answer in these two. Pulse energy is very high in holmium. Holmium is a water cooled laser with a lot of mirrors in its design, and holmium fibers are bigger when compared to TFL. Decidustat is the first erythropoiesis stimulating factor, oral erythropoietin stimulating factor for anemia and CKD. It is an inhibitor of hypoxia-induced factor prolyl hydroxylase. Collagenase Clostridium histolyticum. It is the only intralesional injection for approved by FDA for Peyronie's disease. Thank you all. Thank you, SOGUS, for giving me this opportunity to conduct the Visesra PG quiz. Thank you, sir. Great, sir.
We'd like to invite Dr. Bhagwan sir to give the memento to Dr. Ravi Chandra Puvata. For the next session, we have a program on robotics in renal malignancy. The moderator for this session is Dr. M. Gopichand sir, and this session will be chaired by Dr. C.H. Naidu sir, Dr. Rakesh M. Sharma sir, Dr. Sanjay Adla sir, Dr. Syed Ghaus sir, and Dr. Priyatam K. sir.
At the outset, I think we must all appreciate the efforts made by Dr. Yakaya sir, one of the best conferences that we have seen. The ambience in the theater, the ambience for lunch, dinner, we can see his hard work that he has done. Thank you very much, Dr. Yakaya sir, for hosting us here. It was a fantastic conference. Then I would like to thank Dr. Srinivas and the SOGUS Executive Council for having given us this opportunity. We have a small symposium on the robotic surgery in kidney malignancy, and I am very thankful for the excellent faculty that they have agreed be part of this symposium. We have so we have with us Dr. Naidu. We all know, in the shortest period, he is the budding star of robotic surgery. He is at Vizag. He would be talking on the robotics in kidney malignancy. He will be giving us the introduction. Then we have Dr. Rakesh Sharma with us. I would request Dr. Rakesh Sharma to join us. We all know Dr. Rakesh Sharma. He is with Indo-American. He is a uro-oncologist there. And he's been doing a lot of uro-oncology work there. So he'll be talking on the advanced kidney cancers, how to deal with it robotically. Then we have Dr. Sanjay Adla. He doesn't need any introduction. Mentor for many of the robotic urologists. He is at Apollo Hospital. Then we have Dr. Gauss, part of an institute which does one of the highest number of robotic kidney surgeries, I think, in the country. And he is one of those who is instrumental in that. I am there, and Dr. Priyatam is there. Dr. Priyatam was with one of Dr. Sudhir Rahul for a long time, and he's a apt person to talk on the newer robotics because he has seen a lot of the newer machines as well there. Dr. Priyatam is in Vijayawada. He is a urologist and a urological cancer surgeon in Vijayawada now. So I would request Dr. Naidu to take over and start the proceedings.
Morning to you all. Today I'm going to talk about robotics in kidney cancer. As you all know, the incidence of RCC is increasing over the past decades due to availability of good imaging techniques, and it represents around 2 to 3% of all the cancers. So now the world is towards technology. Open surgery is entirely replacing by laparoscopic surgery. Now it is going to replacing by advanced technology robotics. Robotic surgery is a modern approach to surgical methods. It is a form of minimally invasive surgery with master-slave manipulator. It was launched in 1996 by Intuitive Company, and now the fourth generation is running, that is XI system. But today I'm talking about SI system because most of the surgeons here are still using SI system now. These are the common advantages of robotic surgery over laparoscopy, having 3D vision, motion scaling. Most important is wrist articulation and tremor filter with great magnification, and the precision is beyond the limit of human hand. Here you can appreciate the suturing technique with robotic surgery is more because of magnification and wrist articulation. It is very well appreciated, good with robotics compared to laparoscopy. Age and size are never a limit. Smallest baby is around 5 days old and with BMI around 82.5. Everyone knows partial nephrectomy is very well, robotics is very useful in partial nephrectomy. And not only that, and with large tumors with dense lymphatics, even radical nephrectomy robotics is useful. And with advanced procedures like IVC thrombectomy and radical nephroureterectomy, robotics are very well useful. Before going to the procedure, is a practical point is you have to reverse the point so that patient can't straddle the corner of the bed base. Coming to the position, it is a plank position with the 15 degrees flexion at the midpoint, and the upper arm, sometimes there may be clash with the robotic first arm. So be careful while placing the upper arms in order to avoid that there is a modified position that the patient hand you have to tug with the body so that we can prevent the restriction of the robotic arm movements. These are port placements. It's almost like laparoscopy. You have to triangulate the ports towards the renal hilum. The 12 mm port, that is a camera port, is around 4 to 6 centimeters above the umbilicus, and 3 robotic arms, robotic ports, 8 centimeters each, and 2 assistant ports around the periumbilical region, 4 centimeters away from the robotic ports. And on the right side, you have to use extra port for liver retraction. As you all know that kidney surgery, the space is very less compared to pelvic surgeries. So there are chances of clashing outside. So to prevent that, better to use robotic cannulas for kidney surgery instead of routine cannula so that you can prevent the clashes outside. So a word to about exercise system. In exercise system, no need of any triangulation. The ports are in a straight line. This is the port placement on the left side. Similar, like you have to triangulate the ports towards the hilum. About the docking of the robot, you have to dock the robot 15 to 20 degrees in the cephalad position over the patient arm. The instruments are the right arm you have to take monopolar curved scissors, and the left arm most of them you are using fenestrated bipolar forceps or Maryland, and fourth arm progress forceps. Other gadgets in robotic are this recently the robotic bulldog clamps are available. They are more safer and more precise for placement and removal, and more flexible in angle placement. It is an air seal system to maintain the pneumoperitoneum even with aggressive suctioning and for effective smoke evacuation. Everyone knows intraoperative ultrasound is very much essential for partial nephrectomy. This is here you can see drop-in ultrasound probe, and then another technology in robotics is tile proing. You can incorporate the images like ultrasound or CT over the robotic screen so that in real time you can assess the CT imaging as well. That is the tile proing technology. Another one is fire flow fluorescence technology. By injecting the ICZ dye, we can appreciate the renal vasculature, especially very useful in partial nephrectomy. Coming to the steps, essentially similar whether it is a laparoscopy, whether it is a robotic surgery, there is no change. Here you can appreciate after the gonadal vein, we have to lift it up, and I'm trying to create upper window as well about the right renal vein. So the movements are very precise and safe. You can dissect the perihilar lymphatics very well with both the instruments. I'm searching for the renal artery, so I could able to find the small renal arterial branch here, and my assistant placed a clips for the renal artery there. Once the clips placed, you have to cut the renal artery. Here another advantage is no need to change the instruments at all. Those two instruments we can dissect and we can cut. So I always try to loop the renal vein even in laparoscopy also. It allows me to dissect very well the renal vein, because on the right side especially is very short renal vein. So if you loop it, we can dissect well to place the renal clips also, hemolog clips also we can place very well with this loop. And it is also helpful in identification of the renal artery, because most of the times renal artery is situated below the renal vein. So now I could able to find that artery main branch, and I'm assisting my assistant to place the clips in a better position. This is also another advantage with the robotics. Once renal artery is finished, so we are going to clip the renal vein now. So here, if you can appreciate the the loop is helpful for placement of clips as well. Usually, we put two clips on the IVC side and one clip on the patient specimen side. Once proper clipping was done, we can cut the vein with the scissors. So now renal vein is completed. Once renal vein is completed, you have to tackle the renal lymphatics, because in cancer most of the lymphatics are studied. So you have to tackle with them. Once it was done, so you have to cut the renal artery. Now the hilum is almost finished. Renal artery, renal vein, and now the perihilar lymphatics. Carefully, you have to buzz with the bipolar grasper, and you have to cut those perihilar lymphatics. Once the renal hilar structures are completed, how to mobilize the kidney all around. So now I am trying to mobilize the kidney in the upper pole. Once upper pole and in around, all around the kidney is mobilized, the remaining attachment at the upper pole you have to dissect. While dissecting it carefully, because of the good magnification, we can identify small renal arterial branches or any X-ray veins also we can identify and clip it. So that is the advantage with robotics. Today, the robotic partial nephrectomy in detail they are discussing anyway today. So other indications are robotic IVC thrombectomy. The indications are level 1 thrombus and level 2 thrombus, and better to avoid in level 3 thrombus. So because of the precision and safer dissection, we can easily extract the thrombus well, and major advantage is with the suturing. IVC suturing is very good with robotics compared to laparoscopy. Here, the robotic radical nephroureterectomy, the first docking in that fashion to remove the kidney, and then you have to redock the robot in this fashion to take a adequate amount of bladder cuff. A word about robotic retroperitoneal approach, because most of the Western surgeons are practicing well with robotic retroperitoneal approach. It is more advantageous for posterior and lateral tumors, and the main advantage is rapidly onto the vessels with minimal dissection, and is very much useful in previous abdominal surgeries. So disadvantages are smaller working space leads to clashes, better to avoid in hilar and anterior tumors. This is the positioning, full plank anti-trundling for position. So this is so with this I am concluding my talk, and thank you.
Fantastic. Thank you very much for a real overview of the whole robotic usage in kidney malignancy. We have Dr. Rakesh Sharma, who would be now telling us about advanced kidney cancer, the various techniques that I think Dr. Naidu just showed us how suturing and all in IVC. He'll be talking and elaborate regarding that. Meanwhile, we can take one question for Naidu if there are any. You have any question?
How do you choose which instruments to use? I know there are quite more laparoscopic surgeons than robotic surgeons here.